Yeah. I mean, there are a few more people short than when they started, but that's normal. All right. What is spoken as a clinical picture is not just a photograph of a man sick in bed. It is a professional painting of a patient surrounded by his home, his work, his relations, his friends, his joys, his hopes and sorrows, and such. Okay. And it's supposed to be in the inverted pyramid reasoning. So anyway, ideally how this all works out is when you get dispatched somewhere. Something happened to somebody, you get dispatched. Try to get information from you. Or the dispatcher tries to get information. Understand it's one thing you're going to realize in the continuum of information, it's either one, you don't get too frustrated when you run into a bunch of loopholes after loopholes after loopholes, especially if you're going to say, yeah, I got called to chest pain and I found out, or oh, here's one, I got called to difficulty breathing and I found out it was somebody with a cold. Or it was, so I called to difficulty breathing and it was actually, nausea. It's just, the system, a lot of it's just, comes with the whole, EMD, the emergency medical dispatching, it's just a flip chart. Do you have difficulty breathing? Yes. Upgrade this response, call it that. If you have chest pain of any sort, okay, yes, we're going to call it chest pain, okay, we're going to give it this response. You could have chest pain because, you've been coughing all day, but that's all it's very dry that way. It's not very, really getting in depth. They just kind of want to get a quick gist, how fast to send you and how much to send over there. That's all they're really concerned about. So anyway, information, chief complaint, the environment. Environment's going to say a lot of things. And the kind of think of environment is actually inside anybody's home or apartment. That's going to tell you a lot about a person right away. Or just at least their living conditions, or, you go walking in, you see about 30 cats running out. That's usually the beginning of a very interesting call right there. And then you hear the lady, "Don't let all my cats out! We don't want to go outside." And they're like trying to escape out for dear life. This is it. We're finally out of here. But yeah, look for, again, are you outside? Are they homeless? Is it an office building? Are they working around chemicals? Not chemicals. Are they been working a fire? Things like that. The idea is what we want you to do here is what they want to come up with the differential diagnosis. So if I say chest pain, what can cause chest pain?
Heart attack.
Heart attack's a big one, right? What else?
Fracture.
Asthma. Yeah, actually can. Pneumonia.
Fractured rib.
Fractured rib. And that's what they kind of want, really, you'll see this.
Heartburn.
Huh?
Heartburn.
Heartburn, yeah.
I hear a lot of that.
Yeah. No, heartburn's another one. Yeah, the big thing that you'll run into when you go out to in the field, preceptors will just sit there and ask, give me 3 differentials for this right off the bat. Even if you go in there for leg pain, I got pain in my leg, 3 differentials right off the bat. What could they be?
Pulmonary.
Muscle.
No, not pulmonary. That's
This is what DVT.
DVT.
Pulled muscle.
Pulled muscle.
Nerve.
From
Pinched nerve.
Nerve fractures. So yeah, get ready to shoot those off right away. And then, like I said, that's the one thing they'd love to ask you. Me personally, like I said, I always kind of go with things of 5s and work your way down. Seems like 5 always works, and that's kind of actually how I question a lot of things. If I sit there and say you have chest pain, I'm going to try and figure out 5 questions that's going to lead me to one of those, and then I'm going to try and narrow down at that point. But ideally, I think broadly, even if it's very obvious, it's an MI. Okay, it's just the worst MI there is. This and the other. Make sure there's nothing else going along with it. Okay, you can have chest pain and you can have renal issues going on at the same time, or you can have chest pain and you can have a bleed going on at the same time. So you just be careful of that, and that's something if we start doing more lab time, I'll throw these things, especially if I think you guys are really honing in really quick, or you're just not being very thorough. I'll start putting in little extra things to see if you're paying attention. But that's and then like I said, that's, and you know, I've actually had a lot of students get frustrated with me about that, but that's real life. You're going to run these people that have so many, you know, comorbidities all the time. You know, it's like, okay, you know, are you having chest pain because you're having your history of anxiety issues? Are you really actually having a heart attack this time? You know, is this, you know, it's cold, it's yucky outside, is this a pleurisy issue am I dealing with? You know, you've got to be able to sit there and say, yes, it's like, yeah, even though the EKG is looking at this, let's just make sure we don't have this going on that could make this worse. You with me on that? Okay. So just remember, think very broadly on it. And like I said, it can always be more than one thing. It can always be more than one thing. A lot of times, you know, when you come towards the end of testing and stuff like that, we're pretty straightforward with it. But, you know, well, actually, if I'm around, it won't be. But I don't know. My thing is, if that's what you're going to run into out there, I'd rather just give you what you're going to run into.
That have to figure it out.
Huh?
That have to figure it out.
Actually, what's more fun, you know, especially when you're working with a new paramedic, and they're trying to figure out what they're doing, and you're like, well, what do you want? Well, I don't know. You just slam the doors on them and just get up and drive, because then they really have to figure out what they're going to do.
Anybody tell you your sense of fun is kind of twisted a little bit?
Yeah.
Anybody ever tell you that?
Oh yeah, "Twisted little monkey" is actually the quote I heard.
They said that to your face?
Uh-huh. Oh yeah. I've been called a myriad of things. My first year teaching here, we had a very interesting student, and this person referred to me as Hitler, Satan.
Wow.
I think he was up there.
Yeah. Yeah, I've had a little reputation following me for a while. I think it's like, I don't know what happened to it. I guess I'm getting easier or something. But, no?
He may not agree with you.
Talking about
Right? Easier.
I met a dude whenever I was working the other day, and he said that he remembered going to the class with you.
Who?
I can't remember his name, but he was a bigger guy. But he said you and him butted heads a few times. I don't know.
Big guy I butted head with? Can you give me more description?
He got tattooed. I think he was bald-headed. I don't know whenever he went through the program. I don't know, but...
Is he a fire or EMS?
No, he all I know is he went to the class, but he told me just a little bit. But
How long ago? You knew this guy?
I'd have to say at least a few years.
Good job.
Yeah, Tom?
Huh?
Tom?
Tom.
Tom, I know. Tom.
He was. I think he has to be like in his late 20s, like 27, 28.
I don't know.
Mm-hmm.
No, I didn't.
But I mean, he's actually not working as a paramedic now.
He's not?
No, but he went through the class and everything. I don't know, but
I don't know. I've heard a few feelings, I could tell you that much. But anyway, the idea is a narrowing process. You know, you get your history, you get your physical. Labs we really can't do too much about. Okay? And like I said, you know, what we try to do is we try to make the most of what we do have, and that's why we start playing a lot with like end-tidal CO2, try to look at the different values, different patterns. You'll learn more about the different patterns of end-tidal CO2 when you get in the third semester, like EKGs. Now, a lot of times, you know, you'll hear everybody harping on STEMI. We got to identify a STEMI. You can actually do quite a bit more. You can sit there and you can look for, you know, previous MIs. You can look for electrolyte issues. You can look for pulmonary issues going on. I mean, like I said, that's just us being very, you know, being creative and making use of what we have. Now, in hospital, they don't do it. They're not going to be too concerned about that because they've got a lot more diagnostic tools at their disposal. You know, CTs, you know, MRIs. You know, go figure, right? Labs they can get within an hour. We don't. So we try to, like I said, try to make the most of what we got. And then when it comes down to it, we get the actual diagnosis. What are we going to call this? See, the nice part is once we get down and we can call this, then we just sit there and say, well, okay, well, if this is pneumonia, how do we treat pneumonia? Okay, well, if they're breathing okay, you know, but they're feverish, you know, skin turgor's a little good. Okay, we give them IV fluid, oxygen. We're going to kind of monitor them at that point. You know, it's just getting to that point is probably the hard part of this. It's like, okay, just follow what protocol says, just depending on their severity or not. Okay. Big thing here, you can't treat what you don't find. Okay, you cannot. If you don't look for it, you're not trying to look for it. You're not going to. You're not. It's not going to be there. You know, and like I said, where it gets more challenging is you get those patients that are altered. Why are they altered exactly? You know, it's, or why are they unconscious? You find a guy in the middle of the road, middle of the night, lying there. How about this? A Saturday night. What could possibly be wrong with that guy? Drunk? Diabetic, huh? Overdose?
Traumatic injury?
Yeah, middle of the road, right? Maybe all, huh?
LSD.
Psychological issues.
Yeah, that's a really good one. Psych issues. Actually, I remember years ago I had this lady. She was lying in the road waiting to get ran over. So of course, when we picked her up, she was fighting because she wanted to go back to lying in the road. Yeah. That was an interesting day.
So did you restrain her?
Huh? Well, there's actual funny story about that. So I had to. So we bring her into the truck, and this is the time we actually had to call for a lot of drug orders. We had this drug called the Napsine. And Napsine's a great drug. For whatever reason, it got this big old black box on it saying, "Oh, well, Napsine's bad, kills people, la 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 la." Napsine works great. Chase a little Benadryl behind it, they're out. Anyway, I'm sitting there. They're already wrestling with this chick. I've already got the Napsine already drawn up, and the guy's looking. He's like, "Do you know how to speed load that or what?" Kind of thing. Well, anyway, I had to get on the radio to call for an order. I was like, "Yeah, I need to get an order. This, that, and the other. I've got this patient, da 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 da." And he's like, well, the doctor asked kind of this smart-ass question. Well, do you have any vital signs like a pulse? And as soon as I keyed it, she is screaming. She's like about right here. Ah! No, I don't.
Perfect.
Well, I can tell by her screaming that she has a pulse, and I'm sure she has an elevated heart rate. Go ahead and get it. Thank you. So, yeah. That was one of those moments. It's like, oh, yeah, we always want to have, full set of vital signs before we give any drug. Right. When they're kicking and screaming, trying to bite you and go back to laying in the middle of the road, not so much. So, again, like I said, if you can't find it, you can't gather it, you can't synthesize it, it doesn't exist. So, and that's what it comes down to. If it's not there, it doesn't exist. If you're not looking for it, it doesn't exist. Go looking for it, trying to see what's going on there, try to find out what's going on there. Sometimes even if it's somebody who actually has, for example, like lung cancer or something, ask them about it. How did this start? How did this happen? What happened next? How did your chemo treatments go? How are you after your chemo treatments? At least they can fill you in on all that first-hand information, versus trying to always play catch up, because we can only cover so much in a short period of time. But, or even like diabetic patients who really deal with real fragile diabetics. They're going to know a lot more about diabetes than you're going to. So pick their mind. So, what happened with this? If you're having neuropathy issues, you ever had this, da. So like I said, just kind of make the most out of it. So yeah, good information makes good decisions. If you know what's going on, you're going to know how to treat it. Plain and simple. Okay. Understand that with history, 80% of this is going to be 80% of your diagnosis. See, the nice part about exam, and this, like I said, always, like I said again, my soapbox about doing an exam. Yeah, exam is about 20 minutes, or 20% rather, and it takes less than a minute to do. But most people won't do it. And I'm sure you guys out in the field will probably see that. They'll be like, "Oh, okay, yeah, we get our computer or a clipboard, and on the way." But of the one thing you can get probably the easiest information really fast is out of an exam. The 80% here is like, okay, let's try and figure out what you're doing, And it's kind of almost as one person told me years ago. It's like sometimes don't go into this job thinking you're going to look to save lives, but more like solve puzzles. So this is kind of like, learn how to solve puzzles here. Ask them what's going on. Let's figure this. Let's try this question. Sometimes even those questions completely out of the blue will be the ones that'll be like, you'll catch on to something really quick. It's like, oh, yeah, actually I did have that. You're like, really? Did you have this? Did you have this? And you're like, oh, wait a minute. You got a whole different issue going on here that I totally sidestepped off of.
I don't think I've ever seen a medic do a head-to-toe exam on a medical patient. They always stick to the focused exam. They don't feel the, and I don't know if it's part of that's like if you're a patient, like, I have chest pain, why are you feeling my legs, you know? I don't know if that's like a stigma
it's-
about it or something.
Well, it's not necessarily feeling the legs, but
Or,
like,
I mean, not just that, but other things, you know. Abdominal pain, they may feel the chest, but they may not, you know. They usually kind of get focused for the medical calls rather than, you know, the traumatic.
it's kind of bad. It's kind of bad in a way because let's say you do have chest pain right now. All right. Okay, you've had chest pain. Let's just say it's a 9 out of 10, crushing, the whole impending doom. You're doing the whole Levine sign, right? And I just sit there and I get focused on that whole EKG. I'm going to be dropping nitro and all that other business. Okay, well, what could I find or possibly find by looking elsewhere? Huh?
Maybe the underlying problem is.
Well, let's just start with exam-wise. Let's look at a different area, and what could a heart problem cause?
Lung issues.
Yeah, listen to lung.
Yeah, lung issues. Okay.
Circulatory
Nerve
error.
in the lung.
Pedal edema.
Yeah, pedal edema. Pedal edema. So what does pedal edema tell me?
CHO, maybe? Swollen.
I've got-
Fluid.
No, the pump.
Left ventricle.
Yeah, I've got a heart failure problem. So if I've got a heart failure problem, okay, now what if I start looking up here, and I start seeing this backing up? I've got a really bad heart failure problem, okay? So if I sit there and look at that, okay, and in fact, if I even sit there and say, look on, lay down, and I start pushing on your liver here, and I start watching this go up and down, now I've got, I've got a serious regurg because all this goes right into your inferior vena cava. I mean, it's backing up in the portal circulation. I've got, so the question is, how much is really circulating now? And the thing is, if you're to this point, how long have you had this heart problem, and why is it popping up now? So you could be having this, I'm having an MI, I'm having a heart attack, but I could be dealing with somebody who, like a normal person, has what they call an ejection fraction out of their left ventricle of about 65%. Well, you're having heart problems, and to come to find out all these little signs and symptoms I start looking at, I may be dealing with a person with an ejection fraction of about 30. Where does that put me in the world of scheme of things now? I'm in a whole different issue now, because this heart is maybe ready to go. This isn't just hey, I'm going to drop the nitro, I'm going to drop this, and guess everything's going to be great. It's I may drop the nitro.
And this heart might not come back.
Yeah, I might dilate everything, but you know what? That ticker may be done out. I may have some serious, ventricular hypertrophy issues. I mean, who knows what's going on? I may have to sit there and look to more aggressive drugs to make you start pumping harder. And that's the thing, like I said, that's what you want to start looking for when you're doing this. Like you're saying, when we talk about people who are smoking, well, do they have the clubbing on their finger? So that's somebody who's been smoking a long time and a lot. So if they have that on their fingers, what else could be going on with smoking? What else does all that smoking do to your vasculature and other parts of your body? You see where I'm kind of leading with this? That's where a lot of these, like I said, everybody gets focused. It's like, oh yeah, it's this. And like, okay, that's great, but where are you in the whole game now? Or where's this patient? Because what happens is, I gave this nitro, the patient died, this, that, and the other. Or I give him, this nitro, the pain went down to about 2. But you know what? Like I said, they have an ejection fraction of about 30. They're kind of, those hearts are pumping like this. They're kind of like doing this thing. And so we dilate it even more, and we're even like maybe get a little bit of this. I don't know. So what have you really done to help things? You weren't even aware of it, but you're just sitting there, trap. Hey, we're going to save this, and this guy's already going downhill. You're not even aware of it.
Like when you do yours, are you
Yes,
on every
yes.
single patient just?
Ask him.
Yes.
Yeah.
Have you ever had a patient complain about it? Like, I have chest pain. Why are you feeling up my, ankles?
No. It's on how you do it. It's like it's on how you're touching and say, hey, I'm going to check this out real quick. You're not feeling this right here, right here. And if they ask, I'll tell them what I'm looking for. It's like, well, this is what I'm concerned about here. For example, if you start having, let's say you're calling me because you're having a productive cough with yellow sputum, I might start feeling right here. Like, why are you feeling right here? Well, those are submandibular glands. Those are part of your lymphoid system. You get an infection, these are going to start getting swollen and tender. If they're swollen and tender, then we're progressing.
Or lead you down the path of your
Yeah.
final diagnosis.
We got a more progressive infection going on than just, this is possible bronchitis. That's the stuff I'm looking for. You know, if you really want to get crazy, then you got like, you can feel for lymph nodes here and here. And
Over here,
Yeah.
there.
Yeah. So yeah, it's just, and like I said, a lot of it's just kind of how you go about it. And if you go about, you know, just like they're gonna be like, yeah, get your hands off me. So, don't let your suspicions or patient past history affect your questioning. You know, I mean, like I guess one thing to look is like you're gonna run to like, especially if you go to Austin, a lot of crazy people, a lot of drunk people, but crazy and drunk people do get sick too. So just remember that. It's like, and you know what? Like I said, that might be just something that they live with. You know, it's like, yeah, I know you're schizophrenic, but you know what? Everything shows me you're having a bad systemic infection. You know, if I sit there and say, yeah, you're schizophrenic, that's why you're acting weird, and I blow it off. You know. Okay, physical exam. Obviously, the big thing. We always emphasize this on trauma. You know, trauma's a big thing because, you know, your mind in a traumatic injury, if they're even conscious, your brain is only going to register maybe 3 points of what is painful and prioritize those top 3, and the rest it's not going to really pay attention too much unless you put your hands on it. So if you got, you know, really bad broken arm and maybe a broken pelvis, you might say, yeah, I feel my arm broken, my pelvis is broken, but you may not be too concerned about, you know, all the abrasions and maybe a fractured rib here. Like I said, it's going to take the big stuff in first. So, medical patients, like I said, obviously the people that are unresponsive, because like I said, they're, you know, sometimes they're not telling you, so you have to rely on a lot of diagnostic tools and what you see and what you find. You know. So if I sat there and we found this guy that was just kind of lying there, and let's say he's breathing kind of fast, he's sweating a lot. Oh, let's say maybe he has a this little ulcer down on his right calf or something, maybe a little edema. What do you think could be going on with that guy?
Infection.
Yeah. Diabetic, could be infection with it too. So, like I said, we want to get in the habit of checking things, and you know, plus you got to understand what feels normal. You know, the advantage, at least with each other, you're going to feel what is normal. You know, a lot of patients are going to go out there and you feel what is normal. It's being able to normal. It's like, wait a minute, this doesn't feel right. This must be the abnormal, or at least, you know, in the hospital, they point, yeah, this is what abnormal. This is what this feels like. You know, but you definitely got to get that baseline of what normal is, or generally normal for people. So. The detailed versus focused, a lot of times it's, I mean, obviously, I kind of look at the detailed. It's like, yes, you may sit there and say, yeah, you know, maybe I've got a cough or something like that, and I may focus on that, but I'm still going to come back with the detailed. At some point in time, always backtrack yourself with the detailed. You know, like I said, you'll be surprised. Did I ever tell you about the guy who dislocated arms and shot and all that? Oh, man. So we got called, good Austin story, we got called over to East Austin for this. This lady, she's kind of done her makeshift, I would say like assisted living per se, which is really kind of like she just kind of like built, I mean literally built some like sheds out in the back, and these people are just kind of like MHMR, homeless people are kind of like hanging out there. But that's her assisted living. And she called us up, she's like, yeah, we're concerned about this guy, he's not acting right. The guy's just kind of walking around and all this, and we're like, so, magic question, what's normal for him? Well, he's normally more talkative. Like how? You know, not really things. So anyway, we start talking to the guy. He's kind of moaning and everything. And it's like, you know, like, does he drink or anything? Yeah, we know he's a drinker. Do drugs? Yeah, I think he does some drugs from time to time. He just kind of walks away from all this stuff. I'm like, well, we're not getting any answers. Like, okay, we're just going to go. Again, typical homeless guy, you know, clothes are nasty, smells nasty, all that. So anyway, we're like, okay, let's start working him up. Start working him up, all of a sudden, like, shoulder's dislocated. He'll just walk around. That's interesting. Look at the other one. Wait a minute, that one's too. We listen, like, and we're sitting there, we're like, what's this little wound here? He's got this little wound going on right here. Like, okay, whatever. We're listening, everything just, you know, he sounds like he's got pretty lungs and all this other business, you know, but everything else, you know, that he's hemodynamically stable. Truck him on down to the hospital. Doctors go in there, they're having a heyday. The one where he reduces the shoulder and like, maybe we ought to get an x-ray of this, the other one before we do this. They go take him the x-ray. He's got a bullet in there, and it's healing over. And he's got a little bit of a hemo sitting in there. So this guy's been walking around they figured he'd been shot about 2 weeks ago, and he's just walking around. And we're just kind of like, we don't know what this is. Yeah, we kind of found this, we looked for this and everything, and it's like, that was a bullet hole you found. So, yeah, that's what I'm saying. If I would have done the more focused exam, I would probably have done the whole altered mentation, AIU tips, whatever kind of thing. I probably would have blown all that off. But like I said, you go looking at those things, you're like, ooh, this is interesting. So, diagnostic tests, generally diagnostic tests, you kind of really just want them to confirm what it is you already know. But I mean, don't get me wrong. You will find things out that'll kind of catch you off guard. But I'd say about 70%, 80% of the time, it's more or less just confirming what it is you already think is going on. You just want to confirm it. The other flip side, again, know the instrument and its limitations. Like I was telling you about a pulse ox, it reads near red, infrared, just binding of hemoglobin. That's all it looks for. Nothing more, nothing less. EKG. EKG is not going to tell you ejection fraction, but it's going to tell you, electrical conduction. Are things, going down the pathway they shouldn't, or should not. It's all going to tell me. And again, like I said, all it's going to do is present patterns, So, and again, the big thing here is always treat the patient, not the instrument or the numbers. A lot of times you're going to see some of these people. In fact, there was a story I heard a while back. Patient gets brought in, lady. She's, I guess she was like 70, 80 years old, and she had a little blood pressure of like it was like 80 over something. I know it was a good 80 over something. And anyway, she was feeling kind of lightheaded and kind of, not too well and everything. Well, they go do, everything else. Pulse, check, pulse is fine, lungs fine, heart's fine, this, that, and the other. She's upright, talking, color's good. So is this a bad thing right now? No. Do you want to play with this at all? Well, this individual gets sucked on to that number is 80. I have to fix this. They get fluid. Nothing really happens. She says, yeah, I'm just still feel kind of yucky. Dopamine. Okay. Dopamine makes your vessels constrict, and it gives your heart a little bit more pump to it. Come to find out, this person had a GI bleed. So, they're pushing blood through that GI bleed, that non-compressible wound in your belly. See a problem there? Mm-hmm. Presentation is good. Don't ruin a bad thing. You know what I mean? It's like, yes, be a little prepared, but let's not make it worse than it is. So, pattern recognition. What you're going to see here with, obviously, when we talk about different disease processes, we're going by patterns. That's all we're doing. We're going by patterns every time. Or say presentation presents with da-da-da-da-da, because they have patterns behind it. The pathophysiology creates this effect, and this is why you have the resulting signs and symptoms that go with it. So the big thing here is, like I said, the actual medicine part about it is pretty clear cut in the book. The situational part is going to be, you're going to have to actually that's something that's very hard to simulate. Especially dealing with like the different psych patients or domestic violence issues or things of that nature. That's one of those things you just got to kind of learn as you go along, and whoever's precepting will kind of point out those patterns to you and say, well, look how they are talking like this, this, and this, and it didn't really kind of register in there. For example, like some patients, they may hide information from you. So they'll give you this inconsistent story. So the question you're going to ask, is this person really sick, or are they trying to hide something from me? Where am I? People who hide things, you'll find out, or try to play different things with you, they have their own patterns to them. So just look for patterns. So again, expand your knowledge base. We're going to have plenty of that when we start playing with all the patient assessment stuff. And again, obviously, the direct experience is obviously what we're doing here. We're trying to build you, a base and go out, you get clinicals, get a direct experience. A lot of indirect experiences, basically, is the things you just kind of figure out over time. So diagnosis understands a combination of pattern recognition and intuition. we've always got, I don't know if they kind of touched about intuition and EMT school at all. They always say probably intuition and all that stuff. Intuition to me is kind of a nice way of saying somewhere back here has recognized something I can't recognize up here. And instead of saying, hey, you're missing something, hey, you probably ought to do this. And that's how sometimes they'll say, it's like, yeah, we're pulling somebody out of a car and they're not complaining anything. It says, we probably have to put them on a backboard. That person may be recognizing something we don't. So base treatments on your plan. Again, what's your diagnosis? Once you named your animal, okay, well, what are our protocols and standing orders for treating this? And again, you're going to know some with protocols. It also depends on severity. Low acuity might be, like I said, just IVO2. Transport, high acuity, we might be sitting there dropping some more drugs and getting a lot more aggressive with it. It just depends. So, and again, the last part here is professional judgment. Again, this is what obviously you're here to develop. It's just getting that judgment. And the nice thing about at least being here is you're going to be around lots of residents. Pick their brain. They've gone through how many 4 years of med school, and now they're out doing this. Pick them for everything they got. Factors influencing assessment decision making, personal attitudes. It's hard, but sometimes you might sit there and say, yeah, this person's kind of a dirtbag because you ran on them for the umpteenth time, but you don't want to kind of get that in the way. You want to talk about weird ones. You talk about how would you process this in the future. We get called for this kid having chest pain, 24 years old, right? We come over, it looks like at this, again, HEB parking lot, by the way, 7th Street.
Seventh.
Mm-hmm. And so we're there, and we're like looking, what's going on. The kid just comes sprinting up to us. I got chest pain. Okay, put him on the monitor. Well, anyway, he actually has a pretty semi-significant heart issue going on. He got chest pain. It's like, oh God, we got. This kid, he's actually having an MI, and we're like, talking to him and everything. He's like, yeah, I do lots of cocaine and crack and everything, so he's fitting the bill. Go rolling into the hospital, roll in the door. You should have seen them. Him again? We're like, what? It's like, I bet he called in complaining of chest pain, didn't he? Yeah, he does that quite a bit. But yeah, it was weird. Again, it's hard to separate. They treated him appropriately, the EKG and stuff, but it's kind of like, what if you see that guy coming by again? Is he going to be crying wolf this time, or is there going to be something legitimate behind it or not?
So he had a legitimate heart.
Oh yeah, he cracked himself out good at one point. But the thing is that what he had been there for quite a while. But if you didn't know the guy,
So he knows that, and he's just using it.
he's playing the game.
So what is he trying? The drug seeker? Is
Some
it
of them are.
ER?
Yeah,
Because there's.
Just attention.
detention too. It's
Food.
Yeah.
Lunch.
Free hot dog.
yeah.
Bed.
Yeah, so it's hard, like I said, especially if you have routine psych patients. It's going to be hard. Like, are you just calling because we're having a psych issue again? It's like, well, like I said, don't let that get in the way because, like I said, psych patients get sick too. So uncooperative patients. I think a nice way of saying here's one of those. We're going to test your patients kind of a thing, because, like I said, some of these guys they're just trying to, they just want to push your buttons. And that's all they're trying to do is push your buttons. So, you kind of ask yourself, is this person really sick? Or is this person just kind of normally a jerk, but they're really sick? That's a tough thing with uncooperative patients. Patient compliance, again, how willing they are, to help you out or, do whatever procedures you are. Or, again, kind of same thing. You kind of get that frustration. Distracting injuries. Something that's not just necessarily distracting injuries, but sometimes you can actually put this as distracting injuries is pretty kind of easy there, because, like I was saying, the patient's brain is only going to register 2 to 3 things at most. It's not going to notice the other things. Think of this as the other you might run into is like distracting discomforts. I can remember this one guy we picked up, car accident, doing the whole I've got neck pain, take me to the hospital. As soon as we put him in a collar and laid him on his back, he was screaming bloody murder. He could not breathe. He kept going on and talking. He was
He was screaming that he couldn't breathe.
the thing is, this was bothering him. So, this was was distracting. Now he wasn't too concerned about that now. Even though he, like I said, I mean, the guy was full
Just leave
sense
it
of,
on?
huh?
I mean, you might have taken it off.
Hmm?
Just leave it on.
It's one of those, you tell them, it's like, I'll take it off, but you understand you're going against medical advice and have to have you sign something, da-da-da-da-da, so you don't get held liable. And sometimes they may be compliant and sometimes they may be not. If they're not, my thing is if they're not willing and they're not, well, the thing is if they're not willing, per se, then I have to go into questions, do they really understand me? Or are they too consumed with that? If they can't understand me and can't really recognize the consequences, I have to sit there and say, no, you just stay on there. And then they just, they freak out and, you can give something to calm them down. But that's just kind of me. A lot of times, like I said, I mean, I'm thinking of another guy in Colorado. He wouldn't say a word to us. In fact, he even tried calling his doctor for us, and I'm like, they're going to tell you to come with us. And he ended up, he called his doctor and said, yep, go with us and everything. And I told him straight out, I'm going to document that I told you to come here. I'm going to document that you sat here for 20 minutes. You're moving your neck around. You didn't want to be touched, da-da-da-da-da. We're not going to be held liable. So anyway, we get him on there, put him on board. I get him trying to sign. He writes this big old. I even read him. By the way, he's always like, "What am I? I need you to sign." He was like, "What am I signing?" I'm like, "You're signing. It says this, 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 this." Oh, okay. And he writes on there, "I did not read this. I don't know what this is about." I mean, he writes this on the thing, and so of course I write my little note. This was read to patient. Here are the witnesses, kind of thing. Turns out, again, like I said, he's trying to wind things up. It's like, so the question is, does he have legitimate injury or not? He's too busy doing all this versus he's dealing with his actual neck pain or back pain. Here's the other side to the side of the story. Found out what happened was he was at fault for the accident, and he'd been taking a bunch of drugs and muscle relaxers. So, again, like I said, distracting, whole different issue. Kind of have to worry about here. So, environmental considerations. Environmental, like I said, just not necessarily the great outdoors, but like I said, home environment, life environment. Cultural environments can help kind of just, change those things. Personal considerations, I don't know, safety issue. What are you going to think about that patient if they might, could be a potential threat to you? Kind of a thing. Thing also got to worry about was something with some of these other personal considerations, like those with kids. Some of you guys with kids, you start dealing with patients, dealing with child abuse. I mean, or you actually, let's put it this way, you get called to a child abuse call, and it's possibly one of the family members who did that is now telling you have chest pain.
The dad broke his hand punching the kid.
Huh?
The dad broke his hand punching the kid.
Did I ever tell you I haven't told you that one either. Sitting in front of a mall one day.
Oh, with your partner, like the punching
Yeah, you
them?
started punching
Y'all were
the
sitting
kid
there in
in
front of
the
the mall or whatever?
Yeah,
and
sitting in front of the mall. The guy, we're sitting there, and all of a sudden, my partner says, "What?" I'm like, "What? Here's this guy. He's holding his 16-year-old girl. Pow! Pow! And we're like, it was one of the things like, what do you do with that? So we're coming out there, we're like, what the hell's going on? He's like, "I'm disciplining my daughter. I'm disciplining." What? You need to stay out of this. What? Like I said, how do you process this one? Because you're not a cop, obviously. It's like, do I?
No, but you got a radio to call and right there.
Oh, they came. So anyway, what ends up happening is, cops sit there, they take him down. Well, he decides he wants to resist arrest.
Oh, well, good.
So of course we're watching this. We're going.
Yeah, exactly. He's getting a little bit of that.
So and then on top of that, as soon as they throw him in the cop car, guess what he does next?
Chest pain?
Did y'all really have to run him?
We had to walk over there and talk, and so I'm talking to this guy, and I'm trying, and it's one of the things. I mean, with me in my mouth, I'm like trying so hard not to make any comment that could come back on me because I had several ready to go, but like I said, that's one of those things that was kind of influencing. Like, just keep focusing on what you're doing, focusing just chest pain. Then he was kind of trying to play squirrely with me, and I'm like, if you have chest pain, like we're going to the hospital, I will be starting IVs on you. I will be doing this. Is this what you're telling me? Because he's trying to, again, he's kind of playing his game. But he's like, no, I'm fine. Leave me alone. Da 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 da. But that's what I'm saying. How you'll get in those really weird situations of, again, But here's the flip side. What if he actually was having an MI?
Yeah, he was having a heart attack.
Yeah, right after he beats his daughter in public. So.
It's pretty slow.
He deserved it.
Drugs. Suffered a lot.
Karma?
So personalities, preconceived notions, short circuit. Again, like I said, we can kind of get a little bit stigmas of like the frequent flyers. You're gonna see a lot of those. Again, like I said, just again, those people, just they kind of want to push your buttons. I don't know, maybe they're just generally angry at the world. They blame you because they're homeless. I don't know. But the big thing here is to point out is always rule out a medical before you start going with the psychological. Always rule out the medical first. A good head injury guy. So down on I-35, you guys know where about 32nd Street is? Anyway, on the lower deck, a semi rolled over. Pretty impressive to look at. So we're coming out there and everything. Well, okay, this is so classic. So way down here is this really attractive girl that was in the accident. Guess who's over there?
The patient.
Uh-huh. She is one of the patients.
Your partner?
No, the fire department. All of them were over there, by the way.
Freaking
And
truck
the truck's
driver whose
flipped
truck's
over.
on fire.
Yeah.
man.
So there's this other guy lying in the road. The guy's sitting there. Guy's like, "Hey, you need to come check this guy out." So I come walking up and everything, and I was like, "What's going on?" I was like, "Yeah, he rolled his car." So I I pulled him out. I'm like, "Okay." So I go over there. Of course, my partner's like, "Well, you're over there. I guess I'll go walk." Again, he's about a good, 50 feet. This lady's now a good 50 feet, and again, the whole fire crew's there. Anyway, I get down and I go, "Hey, what's going on?" Well, he starts trying to fight me. I'm thinking, this guy's head injured, and I'm thinking. So of course now I'm trying to hold and pin him down because he's not coherent to anything I'm saying. The other guy he's there, he's helping me out. Then on top of this, homeless guy comes up. He's got this random
The one that you were trying to get off the overpass or whatever?
No. Random homeless guy comes up. He starts yelling at us about the way we're treating this guy, and I'm like, dude's head injured. Back off. You guys are just this. And finally the cops go. I'm like.
Hey, take
him.
out your phone and record it.
Huh?
Tell him to take out his phone and record it. Is that better? That's all I'm listening.
Oh, no. It was just more like the cop came by and I'm like, and, whisked him away. But yeah, the guy was sitting there combative, head injury, and of course, my partner comes walking, I'm like doing this, the guy was a pretty stout guy, so I'm like, doing one of these things on top of it, trying to keep his head, in line, but because he's just trying to do this to me, and he's on the radio like, everything okay? I'm like, get up here. It's like, I got a head injury up here, and finally everybody comes running up, but yeah, good times.
Yeah, some random homeless guy.
I thought you were going to say he helped pull feet behind him.
No. Random homeless guy was trying to interfere, and again, me being one of those oppressive people in uniform, part of the establishment, we treat people badly, and I'm thinking, this head injured guy is pretty stout enough. He's going to give me a serious run for my money here in a minute, and I'm like, and then I've got to feel about this guy. I'm going to have to deal with two of them at once. But again, the whole point is, like I said, guy lying in the road. What's really wrong with him? He's acting combative. Got a head injury. It wasn't just, you could, the point is I'm trying to lead you away from he wasn't just drunk, rolled a semi kind of thing, or, hey, this guy's just kind of lying here. So. Compliance, these can be, again, positive, negative experiences. Cultural differences, especially if you go into Asian culture, those with real strong Asian culture. Chances are the head of the household, he probably won't even make eye contact with you. He may not even speak to you. He may even talk to somebody else for them to talk to you. And he may even feel less inclined to talk to you if you're female. So you got to kind of worry about that too. So.
Well, and that's not only Asian, it's Indian, Pakistan.
Yeah.
That kind of, I've had some with HEB, and I don't ever speak to them. It's always the husband or the son. It's never the wife or the daughter.
Yeah.
Ever.
Yep. Never. The other thing I would say with Pacific Islanders, they like to get loud and very emotional. I know Hispanic. You'll say Hispanic can get very loud. These guys they kick it up about a few notches. So get ready for they can get very emotional and grabbing each other. They might start grabbing you, and So again, cultural differences. So language barriers, obviously that's kind of a pain because we don't understand each other. So a lot of times it's like you are in the truck and they're like, it's like we'll worry about this later. Again, just
I can just see you doing that to someone and getting frustrated because they don't understand.
no, a lot of times it's like, huh? So again, like I said, distracting injury, the most obvious patient cannot be what's killing them. Like I said, they're concerned about the broken arm, but they don't have the actual innervation to notice that big, bleed going on in their belly. You don't want to be the one passing that up. Again, be systematic, always be systematic, always be systematic, always be systematic. So, and avoid making decisions before you have all the information. So, like a lot of this is just gathering data and then regathering data, then regathering data. That's a lot of just what we do. And, one thing, I'll jump on you guys a lot about being systematic is, like I said, you don't want to think about what do I check next or what should I check. It should be just I'm going. Okay, wait a minute, found something. Okay, wait a minute, I checked this last time, it was okay, let's check it again. Let's make sure, double check. And you're always just repeat. So environmental considerations like scenes, chaos, violence, dangerous, high noise levels. If you guys ever pick up somebody in a rave, that's always entertaining. Passed out in the bathroom at a rave, that's even better. Bystanders. Huh?
We need to go work in Austin.
It's a very interesting world. So crowds of bystanders. Depends on the bystanders. A lot of times they just want to watch, and the thing about bystanders, you got to remember, understand Baywatch is the number one reason why everybody thinks CPR works every time. Okay, so when you're doing CPR and you're like, yeah, I pretty much know this guy's, they're pretty much toast, but we're going to give it a shot, see what happens.
Yeah.
You know that they're thinking this is going to work because they saw it on TV. That's the only thing they have to relate to, even though they know that TV isn't real life. That's what they think. Well, this is what you guys do. They're going to come back talking to you in a minute versus, you start ventilating them, and the next thing you know, there's puke everywhere and all kinds of business. But bystanders can be good and bad. I think I told you about the double autoped.
It's a big crowd of people that were grabbing.
Is that when you were at the wrong station or a different station? There's a big crowd of
You were
African Americans.
you were out of your station. And
Yeah, I was goofing around. That's it gets a good crowd one right there. Angry, drunk crowd at you. That's a little bit scary, by the way. So yeah, it just depends. It just depends on the bystander. Some people will kind of backtrack, but they want to watch. I personally don't have much of an issue with them watching. It's usually when they start trying to get involved when I don't need them to, because they want to sit there and say, well, if you're picking somebody off the backboard, everybody wants to come. Here's what happened. This is a classic example. So let's say, Ethan's here, we're going to pick this person up on the backboard. Bystander comes running up, well, hold on, I want to help.
Grabs on that one
to the
side.
and patient goes like that. That's the stuff you got to worry about with bystanders. They want to help, yes, they want to do something, but sometimes it's making sure they don't cause more of a problem than an actual benefit at that point.
Well, and now they're the big stories, they're using their cell phones to videotape everything that's going on. There's a big story in Austin with the guy that went to jail. He's fighting that. This guy walked up on some cops that were arresting a woman, and he thought they were roughing her up, and so he got out his camera and started filming it. And then the cops arrested him for interference, and it's a huge, big stink.
Yeah. No, realistically, yeah. If you want to,
if you're going to be out there working on somebody, you never know who's going to be filming you and listening and watching.
and that's very, very true. And the thing is, like I said, depending on, again, people's attitudes and perceptions, like I said, here I am wrestling down the head injured guy, angry homeless man at the world is sitting there saying, isn't his perception, anybody, in uniform, we're just all, just beating up on random people. And that's, like I said, that's how they usually go run to the, media with that. So it's kind of sad. I personally don't care. If you want to sit there and take pictures of us, whatever it is we're doing, I don't really mind. But like I said, when they start causing a problem, yes, get the cops. Cops can whisk them away. Too many helpers, not much of a problem as for too many few. The problem is sometimes it's not bad having too many helpers. What's actually bad is having too many helpers and none of them want to do anything. I've seen that. They're all, want to hang out for the show, but they're not really doing it. They're like, hey, I need help here.
County first responders.
I'm just saying. Okay. Stage personnel, a big thing is just you always want to bring, a lot of times when they have a call, it's when in doubt, get the most coming. When in doubt, you start canceling them. It's a lot easier to get a lot coming now and versus getting a couple coming in and then realize, oh, wait a minute, I need this, and now everybody's behind the curve. So personal considerations, again, assign specific tasks, keep people busy, and especially going southward a lot with the firefighters down there. A lot of them are very happy to come by and help, but if you don't need them, they want to go home. And it's kind of I remember we used to have fun with this guy. In fact, he's actually a chief of Leander now. When he used to work, he was a division commander over at Austin for a while, and he was sitting there talking about how he would do his FTO and all this other business, and he had this cadet that wouldn't use his fire crews. So what happened was the fire crews would start doing this. If they wouldn't have them do anything, and they're just standing around because they had their thumb up there. So again, like I said, keep people busy, and that's actually kind of a good thing to do with extra people, especially like family and like in that cardiac arrest or something like that. Here, hold the IV bag. Here, go get this for me. Give them. Those people really need something to do.
Go get meds or try to find a DNR or something like that.
Give them something to do. Give them something to feel helpful. I know, because like I said, they're in a very powerless situation with a loved one. That's just not a good place to be. Here's a big thing here. Do not assess and manage by committee. Okay? If I'm sitting there and I got to go assess Doug, and it's me and Ethan and Clinton and Randy, not everybody needs to take a turn touching Doug. One person can do one job, can do the assessment, talk to you, and then I can say, Ethan, can you give me some vital signs? Can you put on the monitor? Can you do this for me? We all don't need to be talking to Doug and dogpiling on each other. That drives me crazy, by the way. If you've ever run into that, it's kind of like, the best way to think of it is like you're trying to accomplish something and you have somebody interrupting you multiple times. You guys want things to be orderly. Get people do their tasks. Like I said, if you don't need them, clear them out and get what you need done. But, you can only have, one chief, let everybody else be Indians. All right. Take a break.
I feel secure,
Feeling good about yourself now?
Yeah, we're good. That
Self-esteem kind of popping up.
That warm feeling,
Yeah.
it's nice.
Yeah, as long as you don't hug me, I don't care.
You're not a hugger?
Since when?
This will be the part.
Yeah, I was going to say, well, wait, now let me ask you this. When did it start? That'd be news to me. All right, moving right along. Okay, obtaining a history is it an art or a science?
Art.
Yeah, it's definitely a skill. It's just definitely a skill you got to work on. Here we're going to talk about the value of history taking, establishing a patient relationship, elements of comprehensive history, focusing history, and special challenges. So anyway, value is, again, this directs the physical exam. If I'm sitting there complaining of nausea, vomiting, diarrhea, are you going to be checking my throat right away? Saying, ah. Okay. So yeah, again, like I said, what's going on, where's going on, let's take a look at that and kind of work our way, down and around from there. Offers a basis for a differential diagnosis. Okay, like I said, one sign, for example, like high blood pressure can result in a couple different signs and symptoms. Headaches, seeing spots in your eyes, and some other end-organ perfusion issues. It actually causes chest pain. So,
My husband gets really red,
yeah, get that
really
too.
red, like cure up.
Get nosebleeds is another one. I've seen that. So, like I said, it's being able to sit there and say, okay, well, you've got this. Let's see how we can isolate. Because if I sit there and say, yeah, I've got headache, I'm feeling, lightheaded, nausea. that could be a lot of things right there, right? And it's like trying to whittle down, it's like, wait a minute, we've got a high blood pressure issue here. Because we've definitely made sure it's not these, and these things, but we've kind of found our animal here, and this is what we can call it. So again, like, so that's the whole point of a history taking, is that we're trying to narrow down to either that one cause or those causes, because sometimes, you know, like I said, disease processes can bounce off each other, you know, and, you know, potentiate other issues as well. First impressions, what comes to mind when you think of a doctor?
Professional.
Professional,
Knowledgeable.
knowledgeable.
Really high of
Rich?
Huh?
really high of
Hi, oh yeah, well you got a whole different, you know, impression of them. You know, God comp. Have you guys ever seen the Malice?
I watched that the other day when you told me.
Yeah, I'll post the Malice clip, you know, later at break. No, actually, it's just recording. Why not put it up now?
I've never seen the part you're talking about. I've seen the part where he's like, I'm gonna rip out your lungs with an ice cream scoop. I'm gonna like you anyway. Everyone's gonna like me.
That's what you could.
Anyways, we're kind of going on here. Impressions of a doctor. What do we think when we kind of say doctor generally? You know, professional, high himself. I mean, especially surgeons.
The frat boy attitude.
That's a whole different. You know, some surgeons. I mean, yeah, they're pretty cocky individuals, and there are some that are just like, yeah. So, but again, the point is like we. You know, again, first impressions, what do they see, patients see of you and think of you coming through the door, you know. Again, talking back in the day when, you know, when we, you know, some of us would come in, you know, we'd have our shirts unbuttoned about down to here, and some people would come walking in with a cigarette hanging up, you know, behind their ear. Oh, here we go. God damn it. But, yeah, so we kind of left a different impression at that time. Huh?
Oh, yeah.
We should watch one of these and know what's right through next.
My first impression. The first impression.
Which makes me wonder if this lawyer has any idea what kind of grades one has to receive in college to be accepted at a top medical school. If you have the vaguest clue as to how talented someone has to be to lead a surgical team. I have an MD from Harvard. I am board certified in cardiothoracic medicine and trauma surgery. I have been awarded citations from 7 different medical boards of New England, and I am never, ever sick at sea. So I ask you, when someone goes into that chapel and they fall on their knees and they pray to God that their wife doesn't miscarry, or that their daughter doesn't bleed to death, or that their mother doesn't suffer acute neural trauma from post-operative shock, who do you think they're praying to? Now, go ahead and read your Bible, Dennis. You go to your church, and with any luck you might win the annual raffle, but if you're looking for God, he was in operating room number 2 on November 17th, and he doesn't like to be second-guessed. You ask me if I have a God complex? Let me tell you something. I am God. The question is...
So,
why
with that being mind, what would your impression be of that? Yeah. Don't go walking into a patient's. Don't go walking in with that attitude. They'll pick up on that real quick. You know. So yeah, hair not combed. I mean, well, the thing is that it's kind of funny about this. They always talk about hair not combed, shirt tail was out, shoes not tied up. How many guys working 24-hour shifts?
Yeah, this is where you wear hats.
Yeah, end up wearing a hat. You're kind of doing these things. You're kind of walking, hey, what's going on? You know, they're kind of saying, sorry for waking you up. You know, but the whole point is, like I said, making a first impression. You know, if that's just how people are. We're just very snap judgment right off the bat. You know, how you compose yourself, how you handle yourself. I mean, the thing, even with this, I remember one of my partners was telling me is like, you know, 90% of this job is acting. You know, sometimes you have to just act like you know what you're doing, even though you really have no clue at the time.
Fake it till you make it.
You know, sometimes you have to. You know, because I mean, if you start breaking down, other people will start bouncing off of you, and especially, like I said, sometimes when, you know, let's say if you're working with a relatively new group of or inexperienced responders per se, they're all looking at you to see if things are okay, and you have to be the one who can go in there and facilitate things are okay and display that confidence to them and to the patient as well. Because if not, things get really chaotic, and let's just have fun with that. Hmm.
So you have to be like this. Say, it's okay. Everything's okay.
Sometimes you have to.
Even though you're crap.
You're the big man.
Well, you don't sit there and say, you know, I mean, if I, you know, I mean, I'll tell somebody I don't know what's going on, but you know, it's kind of like when they're talking about going to the OR. Don't let them smell fear. You know, don't let patients smell fear either. They'll pick up on it really, really fast. So, anyway, value of history taking 8% of it is the diagnosis in the history. Like I said, it's just trying to question and just trying to get the big picture. So, polite introductions, invited or unwanted pest, you know, kind of thing. The big thing here, this is one of those. Every socioeconomical class is going to be a little bit different. Every culture is going to be a little bit different. It's really the fine art of adaptability. Some people, I mean, we always, you know, try to emphasize kind of a general politeness with people, but sometimes you're going to have to kind of alter and tailor it. And one thing you'll kind of realize is that certain people can kind of get away with certain demeanors that you can't. So, like for example, like the way I'm standing right now. A lot of people would, I've seen, you know, they'll sit there and say, well, don't stand with your hands crossed or anything like that, or doing this, hands on your hips, because some people, you know, take it for whatever posturing it is. I can go in and get away with it. People don't seem to have a problem with that with me. They might with Doug. So you got to kind of learn your limitations and how you kind of build rapport with patients. They might with Ethan, you know, because he's sitting there because he talks very quietly. You know, sometimes he doesn't pick his head up. So if he starts doing this, what would you kind of think at that point? You know, he's really closed off. He's not interested in stuff. So again, like I said, you just got to be adaptability, and everybody's going to kind of, you know, how you show respect to a patient. You know, again, if you come across being a jerk, they're going to pick it up. If you come across that you don't want to be there, they'll figure it out. You know, so, but like I said, just, you know, everybody's going to be a little bit tailor-made. Okay, look at the patients, introduce yourself, handshake, appropriate contact. And again, especially with our little political correct world, we have to be very careful with, you know, how we contact people. Some people handshake, some people don't. I usually don't. You know, right off the bat. I don't know. I mean, usually a lot of times it's like, hey, how you doing? And I'm feeling for pulses. That's just me, though. It's kind of how I operate. So determine the patient's desired name. Just ask them. You know, because a lot of people sit there and say, well, yeah, you know, they're 70 years old. They deserve that kind of respect, this, that, and the other. But they really just want to be called by their first name. So everybody's going to be kind of different on that, and you just kind of have to kind of pick it up. A lot of, in fact, with the military, some of the real old retired military, they want to be called by their rank still. I've ran into that. So avoid disrespectful terms and tones of voice. They'll always try to say, don't call people honey, babe, and it'll slip. I'm going to tell you that right now. But they try to avoid those little kind of pet names with people. And in fact, I knew one guy back in Colorado, he just had this general thing of calling people slick. And one guy just kept getting pissed about it, calling him slick. Oh, I'm sorry, slick. He's like, you know, quit calling me that. So, again, like I said, it's a lot of things you got to kind of consider. Like I said, what one person be able to do and get away with, you may not be able to. And like I said, what you normally do may work for the majority of people, but one day you may have to kind of change it for another. So you've got to be kind of really aware of the person, their, you know, who they are, how you're dealing with them, situations they're in, and all that. So, and again, consider age and culture. I mean, how you talk to, you know, 16-year-old, you know, versus, you know, 48-year-olds, going to be a bit different. So, but again, my biggest thing is just be nice to people, you know. And if you can't, if it's one of those situations they're not being nice, and you know, nobody says you have to be your friend, but then just be professional at that point. Make sense? So, location and position, quiet, private. Ideally, it's going to be hard sometimes. So depending on, like I said, a lot of times this is going to be very situation dependent. I mean, obviously for, you know, females doing 12 leads, we don't want this in public. And I mean, you'll run it, it will happen. Some people will want to do that right there, right away in public. But just be careful with that. If you can, quiet, private location. And sometimes that just being away from a lot of people can actually help you with your patient rapport too. Because especially if it's family and there's an issue with family and something they don't want to talk about with family, and they're all circling around.
Get them in the truck.
Yeah.
Get them away from them.
Get them away from where you do something. So again, try and get them comfortable and calm, eye contact, and position at eye level. Again, the big thing we're going to talk here next is appropriate distance and positioning, and kind of your safety, respect, and personal zones. So, and be familiar with these, that kind of a thing. So, I mean, obviously, most people don't like to be within. When we talk to each other, we're always at least 2 feet away from each other at that point. That 2 to 4 feet range, versus not unless you're actually at, some bars or clubs, I guess, because that completely goes by the wayside. But generally, like I said, as people walking around, we have to keep lots of space away from each other. So, but just remember, especially in an ambulance, you're going to break that 2 feet really quick. So just kind of keep that in mind. You get too close, it's like, why are you in my face? Why are you right here? Kind of a thing. Comprehensive history elements, pre-arrival and call information. Again, take it for what it's worth. Some of it will be useful, some of it will not be useful, some of it you have to come in and say, wait a minute, I thought this was this, we got called for this. A situation may have changed or progressed into something else, so you got to kind of keep those in mind as you're going along there. First impression and the environment. Again, like I said, when you come walking in and you're looking at things, what kind of environment are you in? What does this environment tells you? If you come walking in, what does this environment tell you if nobody was here? It's like, well, obviously we have rows, we have chairs, it's a classroom, we have, one desk up there. Things like that when you start walking around in places, in homes and buildings and whatnot, say, what kind of business is, if I took all these people out here, what kind of business do I think would be here? Or what kind of family life would be here? What's up and around, what kind of pictures are up and so forth. Identifying data, who they are. Chief complaints, again, that's kind of the big thing there of, what's going on today? What happened? So, history of present illness. Again, that's just, we're going to ask about 20 questions about, why you called today. It's like, well, I've got a headache. Okay, well, when did this start? How is it now? How was it when it started? Is it getting worse? Is it getting better? Hearing any ringing in your ears? Are you seeing any spots? Do you have any numbness, tingling anywhere? Current medical health status and medical care. Okay, then we can kind of go into that, meds, drugs, and allergies. If they're taking medications, they're taking them for a reason, right? So, they find out we have an issue of vertigo. Do you think it's start causing headaches? Possibly. So, significant past medical history. Actually, even some medications. They start taking a lot of aspirin. That can give you good ringing in your ears, right? So, significant past medical history. A lot of times it's just kind of ask, and sometimes you kind of have to sift of, okay, this can influence this situation, this could not. It just kind of depends. Family history, this is very important when it comes to like strokes, heart attacks, diabetes, because now we're looking at familial issues that are passing from one person to the next. High blood pressure. And kind of last part here, we're going to talk about, systems reviews. It's basically, we're going to go, pulmonary, circulatory, and so forth. So anyway, pre-arrival and call information. We have dispatch information from the caller. Information could be from the caller, it could be not from the patient. It's just kind of what is reported and what we're going to do about this. Ideally, what happens is we go from, person makes the call. They have usually 2 people there. Person who answers the phone, person who dispatches. Usually those two computers are usually linked up, going one to the next. Person's gathering information, as soon as you get the address, going over, they're looking for the next available unit, say, hey, we're sending you to this, 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 this. And like I said, most places are starting to put little MDCs. You ever heard of MDCs? Mobile data computers in the trucks. Kind of nice, because then you'll see seeing things, reoccurring calls, past police issues, things as they change as they go along. You drive along and say, patient states there is a gun in here, and all of a sudden you're hitting the brakes going the other way. So, anyway, we get all the information, and obviously it comes down to us, and then we're going to kind of sift through everything that we got once we get to the patient. So again, first impressions and environment, clues regarding history. We're looking at the big picture. What am I walking into here? If I walk in everybody and they're all looking like they're smoking crack on a Friday night, chances are they're doing what?
Smoking crack on Friday
On a
night.
Friday night. Is that a problem?
Yeah.
Could be. Could very well be. So, and again, like I said, what's the general appearance of the patient? Lots of, you can tell a lot from appearance just by, again, just take time to look at your patients as you're walking in and say, well, are they breathing okay? Are they tracking okay? Does their skin look okay? You can start, that's actually kind of a habit you want to start doing once you get into more scenario work of, even when you guys start working, in the pavilion there, start saying, okay, as I'm walking in, are you sitting the way the patient should be sitting with this condition? When I come walking in, what does your skin look like? Am I seeing any sweating at all? Are you looking at me? Is the patient looking at me? Are they trying to look away? Are they just curled up on the bed? What are they doing? Take all that information in. Do I see any medications or any therapies used? Is there like a nebulous set up nearby? Are they just kind of lying in a bed and there's like a whole, box of pills? Medical documents, files, anything going around here? Again, just kind of start taking all that stuff in as you're kind of walking through here. Again, identifying data, name, date of birth, gender, ethnicity, physician's name. We're actually pretty bad about getting a physician's name, because a lot of people we run into don't have primary care physicians. But like I said, just name, date of birth. A lot of this is just more demographic information for reporting. Okay, chief complaint, single most critical patient concern. Again, what's the problem today? What can I do to help you? What do you believe to be affected by this complaint? Do you understand clearly? Do you clearly understand the patient's complaint? Because some people are going to tell you. Especially some people here, they'll be just like, I just don't feel right. Okay, what's not feeling right? Okay, what's feeling normal? What's different? And you got to really kind of sift through, because it's just a feeling. And it's actually, especially if you get the diabetics that start having heart attacks. That's usually how you catch them, because they have the neuropathy issues. They may not feel chest pain. They just got a weird sensation. So that's where you're going to say, well, what's not right? What's different? Are you feeling like you're lightheaded? Do you feel like you're floating around? Do you feel like, you're trying to, you're trying to put things in front of them and say, well, which one of these could you pick is not feeling right? Multiple complaints. Okay, again, like I said, you might have to ask them, well, you just say, well, yeah, I've got headache, short of breath, I'm feeling nausea, chest. Okay, which one's, let me ask you this, which one's the worst, or how would you prioritize them from the worst to the least? They kind of give you, a focal range of kind of what it is, what you're going to be dealing with. How much of these are related? How much of these are already, comorbidities existing to begin with? Well, you have to. The thing is, you got to remember, the more complaints, you could be very well dealing with a lot of issues at once. It's very easy to do. So, and again, big thing is we just don't want to sit there and get locked on and say, oh yeah, this is just what it is, and it's like, you understand, you're just having nausea. You're just having nausea. Oh no, you're better yet, you're just having back pain. You're just having back pain, and we completely missed the AAA. That's a good example of tunnel vision right there. You got back pain, put them on a backboard. Back pain, put them on a backboard. Things here, open-ended questions. Open-ended questions are a nice way of saying, we want to ask you something that's going to keep you talking. Closed-ended questions, we're looking for yes and no. Open-ended questions are very good for people who don't want to talk too much. You want to kind of get going. Closed-ended questions are really good for people who are talking over, they're just going on and on and on. You can't keep up with them. That's when you can say, okay, what about this? Yes or no? What about that? Yes or no? Then we can kind of decipher, kind of what we're dealing with there. That's kind of the advantage of using the two different question types. So again, like I said, open-ended, I want you to talk. Keep talking, and I can keep asking questions to go along. Closed-ended, I'm trying to find out specific things, and I'm trying to get control of this patient interview at that time. So listen actively. Act as if you are listening. That's kind of an interesting way of putting it. But again, idea is to facilitate. We want to, I'm hearing what you're saying. Let's keep going with this. Keep telling me more. Reflection. Repeating the patient statements. It's like, yeah, I'm having this. So you've been having this chest pain for the last 30 minutes, and da kind of a thing. Clarifying. Okay, can you tell me what your chest pain is feeling like, or how would you describe it? Display concern, empathy. Saying what you're seeing. I mean, sometimes you have to sit there and say, especially if it's a chest pain issue, is you have to tell they need to hear whether there's something going on, especially when you're putting on the monitor, because that's a big unknown to them. They can't read squiggly lines like we can. You have to sit there and say, okay, look, this is what I'm seeing, this is what I'm thinking of, I think this is the best way to treat it. This is the kind of road we're going to go down.
Can that be detrimental too? Like, yeah, it looks like you're having a massive MI, and now they're freaking out even more on you, which could
It's all
compound this issue.
presentation. It's all presentation. So yes, you're having a heart attack, but this is what we're going to do. We're going to do this, and this is how we're going to take care of it. Like, yes, it's a bad thing. It's kind of almost saying, it's reassuring, but I mean, there's no guarantees. But
Yeah.
like I said, that's how you present yourself. If you say, yeah, you're having a heart attack, that kind of sucks. They're probably not going to be too happy with you.
We'll see what we can do.
I mean, I've had some people, one guy, he had a big old inferior going. He's like, yeah, I mean, that was a real typical, I'm not feeling right. Something isn't right. Okay, how old are you? Yeah, about 50-something. Where'd you come from? Okay, well, we'll just check everything and figure out, big old inferior. And he's like, what's going on? I was like, honestly, you're having a heart attack. Really? Yeah. But he didn't see me panicking about it. And I was like, wow, that's impressive. He's like, everything will be okay? I'm like, yeah, we'll give you some drugs here in a minute. We'll relax. It'll be fine. We'll do everything,
If not, you won't know that I told you it's going to be okay, so.
Yeah, don't tell him that. When you see the light,
Yeah.
Go to the
I
light.
was wrong,
Yeah.
sorry.
just remember, it may not be with you doing this. Hey!
The decision's up to you.
So, yeah, it's a lot of it is presentation. It's how you, I mean, and like I said, when you get out there, and you'll see different people, like I said, again, your own personal attributes and skills, and you'll see people who can develop really good rapport with people really fast, and people who just don't. So ask about feelings. Sometimes you have to sit there and say, hey, scared? Yeah. Okay. Sometimes people it helps them kind of just open up and kind of get that out and going, and kind of relieves their anxiety a little bit. So again, we're going to explore the current illness, and again, like I said, we're always going to look for other things that go with it. We're not going to think it's just that simple. Like this is kind of that big transition from EMT to paramedic is, okay, yes, you've got chest pain, yes, that's 10 out of 10, or, we're going to try and assist you with your nitro. It's kind of like I said, yes, I know you have chest pain, yes, this could very well be a heart attack, but like I said, I'm concerned that, you don't have, ventricular hypertrophy issue because of your high blood pressure, and you have that very low ejection fraction, because if I start giving you these drugs, I might bottom out your pressure, and I might have a bigger problem to go with. So I want to make sure I get as much as I can before I start doing more damage. Okay? Everything we give, just understand you can kill them with it. Everything except albuterol, I think. So you got one relatively safe drug. Everything else, you can knock them dead. Or better yet, like for those who give 3 milligrams per kilogram of etomidate, I saw a lot of, by the way.
3 milligrams?
2 milligrams per kilogram of etomidate. Understand you can knock down elephants. Yeah, I saw that more than once. I thought that was kind of interesting. So.
Fun to try once.
Huh?
Fun to try
You
once.
can do anything at once, man. Murder, you can do it once.
Some people even do that more than once.
Like I said, you can do anything once. Other things you can look for. A lot of times with these acronyms, I usually kind of fall back into acronyms when I can't really think of anything to ask. Or I'm just like, okay, well, what have I asked? Because a lot of times, after a while, you're going to cover a lot of these, you're just not going to go in order. Onset, provocation, quality, region, severity, time, you know. So, I mean, these are good acronyms to remember and always good to know. But like I said, a lot of times it's developing that history-taking style. I mean, I've got a couple different, we'll talk a little bit more, because I got a couple different ways I do it that work really well for me that help me, you know, just dive right in. So, but again, these are guides. They're just guides, you know, kind of get you going. Again, current health status, medications, therapies, are they seeing a doctor regularly? What's their family life? You know, a lot of times, you know, we harp so much on the medical, but the psychosocial affects your medical well-being as well. And you got to kind of look at that too, especially, you know, remember, I mean, you want to see an interesting group of people, postal workers around Christmas time. Those can be some, huh?
When they go postal?
Yeah, I mean, they can be very, you know, you're kind of like, you know, you're thinking, you know, what's the big deal? You sort mail all day. Oh, they're stressed to the hill trying to deal with this stuff. You know, they dread to go to work. You know, you start having that, you know, high stress, high anxiety. You know, like I said, start dumping a lot of cortisol. Your immune system goes down. You start feeling yucky. You know, and so forth and so forth. Other things to look for: recent change of sleep, diet, tobacco, alcohol use, or any kind of, you know, substances that you may choose to.
That's true.
Occupation, immunizations, you know, obviously, you know, we don't have to worry about like coal miners and stuff, but high, you know, stress occupations or being around chemicals, whatever the case may be. Religious beliefs, you know, you may, I don't know, like Jehovah's Witnesses, they can't take blood or certain products, and just whatever the case may be. Or in case of some religious beliefs, we need to take drugs because it's part of our religion. I find that one interesting. Patient's outlook, how do they view life? Are they happy? You know, just in general, you know, general attitude towards things can change their physical and mental well-being. Here's an interesting little acronym for drinkers, by the way. We call it the KH questions. You know, feel the need to cut down, feel annoyed by, you know, criticism of drinking, guilty for ever drank first thing in the morning as an eye-opener. You know. The question is, what if you don't care? I was always wondered about that. Well, you know, do I feel the need to cut drinking? No. You know, do you feel annoyed when people criticize it? No. Do you feel guilty about it? Hell no. Do you do when you wake up? Yeah. I just, you know,
You're an alcoholic? Sure.
gotta be something, right?
How do you good at it?
Well,
You know? So you have past history, again, like I said, what's going on, what are they currently dealing with? How about, like, you know, remission of cancer? That's when they can pop back on you. Autoimmune diseases, some of those things like to go away and then come back. So, hospitalizations, what were they hospitalized for? Surgeries, what kind of surgeries? Yeah, I had surgery in my aorta. Really? How long ago was that? Any more problems with any of your vessels, are you? Oh, not that I know of. That's usually how it kind of comes out. Not that I know of. Or, you know, might, you know, run into, yeah, I've had Barry aneurysms in my head. Really? What are they? Oh, yeah, they put all kinds of, that old string thing, and they wound it up in there, and you're like, oh, great. So they found a couple. Are there any more going on? You guys know what Barry aneurysms are? No, these things are awesome. Let's pretend this is a little blood vessel in your brain. These are little Barry aneurysms. So they fill up, and again, here's all your brain tissue around here, and they can pop. So it's actually what they do is they put like this wire in here, and they coil it, and fill it up that way.
Oh, that's crazy.
Yeah. So little stuff like that you start picking up as you kind of go along here, but like I said, freezing conditions, you know, there's a possibility that they could be coming back, or they're not really well managed. And if they are being long-term managed, I mean, what's the prognosis at this time? I mean, is this something they have to chronically manage? And again, with the familial, like I said, it's all this stuff, so much can be passed familial. You know, diabetes, hypertension, heart disease, asthma, allergies, cardiac dysrhythmias, cancer, osteoporosis, psychiatric issues. So much can bounce from family to family to family. Duchenne's muscular dystrophy is a really interesting one. If you guys want to look up for that one later. You know, and I mean, not even just this, but I mean, like I said, we're looking just purely at genetic issues. Things that just be passed from one generation to the next. Review of systems. This is something I really would really encourage you to always keep in the back of your mind when you're doing this. As EMS providers, we normally really don't do a whole lot of this kind of a thing, but in the hospital, they do this all the time. You know, they sit there and say, okay, general appearance, they'll document this. What was the skin? What was bright pink? This. You know, head, eyes, ears, nose, throat. And in fact, this is more kind of an interesting way of even kind of documenting too. You know, respiratory system, lungs were clear bilaterally, no mucus plugging, good expansion of respiratory movement, does not appear distressed. Cardiovascular, heart sound, you know, good heart, you know, heart sound, good S1, S2 sounds, you know, good peripheral pulses, blood pressure was this. We didn't see any spider veins or any kind of hypertension issues. But just kind of going down, and like I said, just learning how to document this is also kind of learning how to ask questions about it as well. Because if you're not asking, you know, if you want to know how to document something that's gastrointestinal, well, look up those things for gastrointestinal. What things do we need to kind of look for is normal versus abnormal? Make sense?
Yeah, but, I mean, if they're calling, there's usually a problem, some problem you're trying to fix, and you usually only within 15, 20 minutes. And do you really have time to be going through all of this stuff?
Depends how fast you move. I can say this much, if you really want to get a lot done, you can. If you don't, you don't have to. You know, nobody's going to make you do it out there. But, and a lot of the stuff, you're going to be going through this pretty quick anyway, because obviously skin, you're going to be able to see that. Head, ears, eyes, nose, throat, you're going to be able to see that. Worst case scenario, hey, open your mouth and respiratory, obviously you're checking the lungs. I mean, you're moving through this stuff pretty quick.
Like, how would you check the endocrine? Like,
Basically, what endocrine I'd be looking at is, are they having problems with metabolism, for example? Hypometabolism issues, or notice big weight gains, weight loss, sensitivity to heat, cold, you know, things like that. The thing about this is it's you got to get really familiar with what the different systems do, and then when you alter the system, what happens. And again, that's the difference between physiology versus pathophysiology. So, psychiatric, you know, everything okay, feeling okay, not under stress. Oh yeah, I'm doing great, except, you know, I keep hearing voices of God and the devil. You know, so you start seeing all the silver stuff around their face. You're like, oh, I understand why now. You guys are familiar with huffers? Yeah, Goldfinger, Silverado, and Motorhead. Okay, people who like to huff paint chemicals, they always have a preference for whatever reason. But Goldfinger, obviously, they huff gold. The different chemicals give you different types of highs. Russ.
Yes. Well,
I'm having a lot of huffing paint here.
yeah, a couple times.
You know, so, yeah. Gold, I guess, gives you a certain high. Silver gives you a different high, and carburetor cleaner. So. Yeah, it just, you'd be surprised. You'd be surprised what people do to themselves.
Is there a perform a study on this?
Huh?
They'll perform a study on this?
Perform a study on themselves. Anyway, big thing here, general, you know, obvious things, weight changes, weakness, fatigue, fever, you know, general malaise, aches, pains, kind of those broad things. Skin, if you're looking for rashes, soreness, changes hair, nail, possibility related to cosmetics, jewelry, you know, change of soap actually can do it. Say, change of deodorants, change of laundry detergent. But again, like I said, this is a lot of stuff you're already looking at. Your gathering is already looking anyway. You know, all of a sudden it's like, yeah, I kept getting these lesions here. Okay, that's new. Headache, or you know, head. You can do a lot. You know, do a lot with head. You actually can. A lot of times when I think of head, I always kind of blur in the neuro as well. So the thing is like, okay, is your head headaches? Okay, you have ringing ears. You see spots. you know, feel like you're lightheadedness, things are swishing, I mean, you can kind of just go to town on that, you know, about 4 or 5 questions on that. Recent head trauma, you know, eyes, normal vision, glasses, lenses, pain. You guys know what cataracts look like?
They're kind of bluish, or is that the
Because the fog can't to the
Yeah,
lens.
the lenses get all fogged up. They'll actually just take out those lenses and put new ones in now. But glaucoma is built up with the aqueous vitreous, a lot of pressure in their eyes. Ideally, we've always got fluid flowing in and out, but
And that's what they test when they shoot the puff of air in your eyes at the eye doctor.
yeah, I think they're doing for the actual pressure.
So are you gonna see anything left over?
I don't know if you'll really see much with them because we never complain to it. You know, usually they're on some kind of like, let's say they're on some kind of like cholinergic drug. They're just always trying to get the release of pressure. And that's usually, that's also the same one where people are like, marijuana, this is the big fix, marijuana. And THC actually helps with the pain and pressure. You know, hearing, I mean, is it conductive hearing or was it sensory or structural? If there's hearing issues, if you ever get to look up on you guys they still require the physical exam book, green book at all? Yeah, I've actually had a couple tests on how to determine structural versus sensorial hearing. So obviously we don't do it in the field, but like I said, the big thing we're worried about is changing in hearing. What change? Is it one side? You know, is it muffled? I mean, is there something in there? You know, ringing, headache, ear, you know, vertigo, infection, discharge. Okay, nose, discharge, you know, nosebleeds, you know, random nosebleeds. Why are you doing that? Where'd that come from? You know, posterior nosebleeds, that'll be a fun one for you guys to deal with someday. You know, throat, you know, that's so much we can play around with. You know, you got glands, thyroid, bleeding gums, canker sores, cold sores, any kinds of sores that don't belong there. So, you guys know what a goiter is? Yeah, lack of
With
iodine.
thyroid in it.
Yeah, it's from a lack of iodine. Your thyroid actually enlarges because it doesn't think it's has a lot, being able to create enough T3, T4.
Is that mostly now like a third world country because we have so much iodized salt in our food, like
Yeah.
American?
Yeah, I always find that, I don't know about how you guys feel about like Whole Foods and stuff like that. I mean, you guys in here real big, you know, Whole Food eater kind of. Yeah, huh? Yeah. I always find it interesting because they're like, yeah, we don't want these genetically altered foods. It's like, but yeah, that's the stuff that like stops that though. When we start adding that food, you know, iodine and all those things, that's what stops a lot of diseases. And it's like, I mean, don't get me wrong. I mean, I'm nothing against eating, you know, fresh apple or something, but you know, so a lot of the things that they alter now actually have a higher nutritional value than something that we naturally grown.
Well, like vegetarians, they're not getting the natural supplements their body needs, right?
No, they are.
I mean, without like meats and stuff.
I mean, there are some things. I think there are a few things in meat that you're probably, you know, your body would like, but you can live without.
Well, I mean, yeah, you can live without it, but
Yeah,
I guess it depends on what you're looking for.
yeah. So I mean, it's doable. So anyway, neck pain, stiffness, difficulty swallowing. I mean, why are you having difficulty swallowing? We're growing a mass in there. We have a sore throat. We kind of sometimes, you know, angioedema creeping up on us. So let's take a quick break. So anyway, respiratory, again, wheezing, coughing, asthma, tuberculosis, pleurisy, cardiac. Again, like I said, you know, think of cardiac, also go vasculature with this. You know, what should things normally be cardiac and what would be abnormal? I mean, these are actually really, really good things, especially just general questions and things to keep an eye on when you're kind of doing your assessments. And if you know, actually might even be a good idea to make like some 3x5 cards. And you'll punch a hole and make a ring. So that way it says, yeah, I've got cardiac things. You can kind of start listing your cardiac signs and symptoms. Just give yourself those general questions to ask and things to look for right off the bat. You know, just little tricks to kind of help you out.
Like in here when we're doing.
Yeah, yeah. I mean, that's one of the best ways to do it. Actually, one of the best things that worked for me was a Merck manual. Have you guys ever looked at a Merck manual at all? Yeah, Merck manual. It goes through every disease processing and how labs, this that, and the other. But a lot of times it'll start the first paragraph. So this is what it is. This is how it presents. These are signs. These are symptoms. These are things you should ask. That's how I developed a lot of my questioning. As I started looking at that stuff, and it'll start out. Again, it'll go through the whole system. Cardiac. Ask these things at the very beginning of the actual chapter. Then you actually go to the individual chapters. It'll give you a little bit more detailed. So you can start ruling out stuff right away. And then usually it kind of explains why you're asking and what you're looking for, and what kind of the pitfalls and what can kind of mislead you. But like I said, it's developing that questioning to sit there and say, okay, yes, I've asked enough questions about cardiac. We can it's safe to say it's not cardiac. We need to move somewhere else.
What is rheumatic fever?
Rheumatic fever is problem with rheumatic fever is that you end up getting rheumatic heart disease. Okay, and it's an autoimmune issue, and what it is that it attacks your valves in your heart. And I think the big one is it actually attacks your mitral and tricuspid valve, and what it does, it actually makes them very stenotic, so they don't open and close as well, so they're kind of very stiff. So the end result is that the actual muscle tries to compensate and hypertrophies.
Okay.
And then you start getting that left ventricular. The thing is with heart muscle, you stretch it too much, it won't snap back like it used to. And that's the thing I was talking about, the reduced ejection fraction.
Mm-hmm.
That's what you got to worry about, and plus it can actually cause a CHF issue on top of it.
Would it actually do like damage the myofields and actin or something in the muscle?
No, it just goes after the connective tissue. Rheumatoid arthritis, it's your body's. The thing with autoimmune diseases, the real quick gist behind that, all your cells have little flags that say, hey, I belong here. For whatever reason, your immune system, your body doesn't recognize those flags, so it starts attacking them. That's why a lot of people start getting arthritis, rheumatoid arthritis and stuff like that. Systemic lupus is another one. I mean, systemic lupus, they'll attack like lungs, heart, chest wall, all kinds of stuff. Not fun stuff. Those people end up, living on a lot of steroids.
Yeah, one of my really good friends has got lupus, and that once it's under control, it's the steroids that make you sick. And
Yeah.
Anytime she would bump into anything, it's just this huge. She bruised so easily from meds and
Yeah.
tired and stuff all the time.
Well, the steroids actually are basically it's immunosuppression is really what you're trying to do. So, intermittent caudication. You guys actually have fun looking up that one. Intermittent caudication. The hint is they don't like to walk upstairs. I'll just leave that alone. Again, vascular leg cramps, varicose veins. What's a varicose vein?
It's like really,
Having kids.
or people on their feet a lot get it. Like nurses and stuff that walk around a lot in their leg.
No, technically, what it's actually usually your calf muscles. If it's in your buttocks, we call them hemorrhoids, by the way. But they're basically veins, and the valves are no good because you have one-way valves. Those valves, they just get engorged and they get larger and larger, and the blood pools. And I think some kind of worst case. And a lot of times they'll give them those little, stockings that so much blood won't go into those veins, or I think sometimes they'll actually go in and take them out. Blood clots. The one who has a history of blood clots is always a bad thing. GI, we can go in so many different directions because we can start from the beginning of the GI system, working all the way down through all the different parts. So, like I said, this is one of those. Have fun with this one because GI is very, very hard to try and pinpoint in the field sometimes. Just in the GI, I'm not even talking about the actual accessory organs in the abdominal cavity. I'm just talking about the actual GI tract itself. Like I said, we can go from what's in the esophagus down to what's in the stomach to what's duodenum, ileum, ileum, and then we start going into the different parts of the colon, and so forth. Urinary, again, frequency, urine, what's nocturia?
Being at night.
Yeah. hematuria, history of stones, reduced caliber or force of flow, or inability to void. Sometimes you get that one. I mean, that again, pick, ponder questions. A lot of times we're sitting there saying, is it a bladder issue, is it a kidney issue, or is it something within the actual, its own little, I don't think vessels are the appropriate word, but its own conductal system. Because we got the ureters and we got the actual urethra.
So is there something with the kidney stones or the pain from it that'll make you sick? Like just vomit?
Kidney
Coffee
stones?
tobacco.
Yeah. I
Kidney-
just had one. I mean, not me, but the girl that works with us, she started having pain in
Yeah.
her stomach, and so she's, she doesn't know anything about kidney stones.
The
So
problem-
she ends up having to leave and go to the, in the women's restroom, and they find her on the floor, balled up, because the kidney stones hurt so bad, and she's just throwing up. So they think, of course, she's got the flu or something, and,
You're fine. Get back to work.
well, they didn't send her back to work, but,
You got stuff to do.
you're right, get up, get that customer groceries.
It'll pass
But
quickly.
The thing about
is it just like the pain with it, and people just, I know some people can't tolerate pain as much.
well,
but-
the pain is excruciating. The problem is, it's what happens in the actual kidney. What's that? The pyramids. You have I can't think of the name. Anyway, it's calcium. What happens is a lot of times it's calcium buildup.
Mhm.
And what happens is little pieces of calcium break off, and they're little jagged pieces, and as soon as they go down the ureters, they're ripping away, and that's what hurts like hell. The other thing is, when we start talking about the abdomen, it's very sparsely innervated, so it's not like somatic tissue. If you touch me here, I know it's here. Or, versus this, it's kind of, that's why you get a lot of those very vague symptoms with it. Vague, feel nauseated, this is kind of achy, but it's usually, if it's pinpoint and sharp, it's usually more of a muscular somatic kind of thing. Visceral, it's hard to pinpoint. We kind of guesstimate at that point. That's why you'll get a lot of the nausea and vomiting with it too. Female genitalia reproductive. This always seems to be a very, I don't know, this is one of those things that seems to, throw the towel on a lot of paramedics. It's like, well, if it's female, if it's in the abdomen, she's female, we have to say it's female, issued. We don't know what the hell is going on. I think it's kind of more of a cop-out personally, but again, just ask the questions, I mean, again, you haven't, is this first period, or, when's your last menstrual period, are you having issues with it? I mean, how about, run into somebody, I'm 60 years old and I'm starting to have a period again. That's a big cause for concern right there, That shouldn't be happening, That usually spells cancer, by the way. So, but, asking those things, any irregularities, any discharges, are they kind of, walking with a shuffle?
PID shuffle?
Yeah. The So, birth control, hormone replacement therapy, are they taking estrogen replacement, or are they doing progesterone, or is it both? You get different effects from both of them. So. Male hernia discharge, masses, torsions, sexually transmitted diseases, musculoskeletal arthritis, obviously just inflammation of the joints right there, and that doesn't necessarily have to be autoimmune. I mean, that could just be wear and tear issues, to be honest. Joint pain, stiffness, again, we're kind of looking at why. You guys are familiar with gout?
Mm-hmm.
Painful as hell.
You've had gout?
I was taking hydrochlorothiazide, and that was one of the side effects.
Oh, wow.
Yeah, that
Is that for high
sucked.
blood pressure? Or?
Yeah,
Yeah.
that sucked.
That's awesome.
Like the worst pain ever.
My dad had it from drinking.
That's
My big toe.
the
Buildup of uric acid.
Yeah, uric acid.
Uric acid.
Do that.
Don't they they usually say start drinking a ton of water with it or something, or?
Hell if I know. I took colchicine, and
Oh, really?
my doctor took me off the medicine. Never had it again.
Wow.
Like a sheet laying on it in bed was just like, sucked. I
Wow.
remember one time I had to call into work, I could not get my boots on because it was so painful. I was like, dude, there's no way.
Wow.
So I take people with gout pain very seriously when they see my stuff like
I bet you would. Now, I thought there was like, one of them was water, and I want to say there was something else you could drink that actually helped with gout, and I can't remember now. But. So neurological can be fun because, like I said, we have to kind of take a prod. What exactly is the brain doing? You know, what can cause fainting or blacking out? What can cause a seizure? You guys understand the concept? What happens with a seizure? You know, you guys familiar with the ectopic foci and all that business? A little bit. Basically, your brain is a bunch of neural pathways, right? Everything's always going in order, When we start disrupting those pathways, that's when a lot of times we see a lot of the, neurological disorders. One neurochemical isn't keeping, the pathways open. That's all a lot of these things occur. So what happens with an ectopic foci is we end up having this one little neuron there that's irritable and fires randomly and sends discharges in all those open pathways because it's going to go past the least resistance, and everything just kind of causes a cascade effect and starts building up electroactivity. Well, guess what? We got another pathway that goes right back down here, and then it goes out everywhere else. Then we start seeing seizures.
Little bastard.
Hmm?
This little bastard neuron.
It's the rogue neuron.
Yep, it's a rogue neuron. So, and a lot of times we give drugs that really just kind of snow it out, But weakness, paralysis. Brown-Sequard syndrome. You guys want to look up an interesting one later. Tremors, involuntary movement, Parkinson's. Get familiar with L-DOPA and dopamine and how that process works. But anemia. Actually, I did a thing on autoimmune aplastic anemia. That was a very interesting read. Your body starts attacking its own red blood cells. That's a bad thing.
Is that constant
Yeah.
blood transfusion or dead?
Huh? Well, that's the same thing as steroids. We go down a steroid route for immunosuppression. In fact, there's actually, it breaks down into actually cold aplastic anemia and warm. So if the temperature drops below a certain level, it actually triggers the immune system to go after it. It's kind of weird. So easy bruising and bleeding, it's usually a bad thing. Usually, where's the platelets? Why are there not platelets? Why are they not being created? Endocrine. The big thing with endocrine, just if you get familiar with the glands and what they produce and what those glands do, you're basically a couple things with endocrine. You're going to do one thing. Either they're going to try and replace the hormone, or if there's too much hormone, they usually will try to suppress the gland. And sometimes they'll actually try to remove the gland. Like people with hyperthyroidism, again, that increased metabolism, eyes are bugging out, and they're about this thin around because metabolism is skyrocketing all the time. They'll actually take out half their thyroid and let them come back, so they can kind of start coming back down. So that's kind of how they kind of approach it. Or they'll give radioactive iodine to start killing off part of their thyroid to bring their, so that's kind of how they deal with a lot of thyroid. Think about this is with endocrine, it's a big train. One goes to another, can tell the other, keep going. Or like your anterior, like for your hypothalamus will tell your anterior pituitary to drop adrenocorticopic adrenocorticopic hormone. Then it goes down. Then you actually start dropping, your actual corticosteroids, your glucocorticoids, mineralocorticoids, and so forth. So if you got something that one relies to the next, one of those glands can just be offset and cause the same cascade reaction down. A good one is looking up difference between Cushing's, hyperadrenalism, hypoadrenalism, and what was the other one? I think another one is same thing with the anterior pituitary too. So anyway, we'll get to that whole another third semester. We'll talk all about the different glands and how what affects what. You guys know you have a gland on, or most of you, some of you may still have a little remnants of a little bit of a gland left on your heart. Yes, no? When you're younger, your gland, the thymus,
or thymus, yeah.
sits there, and that's how you actually, those red undifferentiated white blood cells come in and they actually start making your T cells at that point. But as you get older, that gland dies off, and now you actually just, your heart has its own fat reserve. Psychiatric. Interesting thing they kind of noticed with psychiatric and neurologic, they noticed a lot of the medications work on both directions. You know, like a lot of Neurontin was actually being used for a lot of neurological issues instead of just psychological issues for like pain reduction and so forth. So, but the psychiatric is, again, obviously big things, depressed, anxious, angry. The big thing is gets really interesting when we start talking to people that, live with, bipolar disorder, schizophrenics and so forth, and just kind of the presentation that goes with it. So focusing on the history, acting on chief complaint, provide immediate care as appropriate. Again, always big thing. Take care of the big stuff. We'll work our way down to the little stuff. History taking may need to be temporarily halted. Again, if they're not breathing, please stop and take care of the breathing. Or, if it's not a safe environment, we can worry about that later. So interpret the history. What do I think of these responses? Do they make it big things? Does all this make sense? If it doesn't make sense, definitely keep asking more. If you feel like you're missing something, keep asking more. If you need clarification, don't feel like you have to stop. And sometimes it's hard when you're first starting doing this because you don't know what to ask. Because you're like, I don't know what to do with this patient. You almost got to kind of prompt yourself to be a little bit more unusually curious, and be like, well, okay, you're a smoker, do this, and that might spur something in your mind to ask the next question, and that's kind of how you start developing your history taking skills. Again, consider an unsolved mystery. We're trying to solve puzzles here. Is what we're trying to do. So focus on the system with the chief complaint. Use knowledge of the anatomy, physiology. We want to know how it works, the way it's supposed to work. The pathophysiology is explain how it's not supposed to work, and what we should see if we start putting a monkey wrench here. We put a monkey wrench here. We'll see these effects, or if we do it here, we'll see these effects, and so forth. Like if you want to see an interesting one, like we talked about high blood pressure here, like you want to look how an ACE inhibitor works. That's actually a very interesting one, and actually how it prevents how it actually prevents ventricular hypertrophy. That's a perfect one if you ever want to look deeper into that kind of a thing, that cascading effect. Why is the patient experiencing the signs and symptoms? Create a picture. Being visual. I know since a lot of you guys are visual kinesthetic, that's how I think of it. I think of the actual pictures of how this is supposed to be working and okay, if I put this here, that changes it here, 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 and here. Now I should see this effect. That's how that's one of the ways I go through it. The more sensitive topics, again, privacy is going to be the big one. And again, it's choosing the appropriate words. Nobody wants to talk about, so tell me how you were raped today. People just are not going to buy that. Okay? Again, it's all presentation, and just like I said, sometimes you just got to be very light, very gentle with it, and work your way to it. And sometimes it's like, yeah, you got to have these questions. I understand, they may be uncomfortable, but was there, vaginal penetration? Was there anal penetration? Be sensitive to the patient's feelings, Ethan. The silent patients. So you guess what the hell?
I roll my nose. Do you want me to do it right here?
No, you just go take a break whenever you want, man. Silence may be normal for some people, and sometimes you got to allow them to collect their thoughts, especially if it's a very emotionally traumatic event. You're gonna have to learn to be very, very patient with them. So, and these are the great ones for the try open-ended questions. If that doesn't work, then default to closed. Kind of a thing. My big thing is with some of these patients, don't make people talk that don't want to talk.
We do just drive them to the hospital then, and
Because to me, if they're not really talking, then they're really not probably in that much pain. Even if
It's
you
a
don't want to
psychological
talk.
issue. Like I said, if
Why
it's
provoke something that's...
seriously, if you got violated, would you really just want to sit there and spill your guts right afterwards? Yeah. If you're feeling suicidal, and you just tried, started cutting on yourself, and you're going to be getting stitches in your wrist. You really want to get into a lot of details of what's going on in your life with a complete stranger for the next 20 minutes? So. Overly talkative patients. This is a good one for the nice close-ended questions, because you got to take control of what's going on, and like I said, it's just they'll try to just keep going and going and going and going and going. So you got to halt them. You got to halt them in there. Big thing on here with the anxious and frightened. Just the big thing. A lot of this is don't give false reassurances. Just don't. Am I going to die? We're all going to die. Kind of a thing. But
Maybe not today.
yeah, maybe not today. But yeah, this is just one of those. I really wish you. This is one of those. If you can get around them. These kind of psychiatric issues. This is you got to learn to walk around and with them, so that everything feels okay. It's a lot of patience. So angry and hostile. Depends how angry and hostile they are. A lot of times, some people will just get very angry, hostile, and they're yelling and screaming, and then after that, they kind of start cooling down. It's when they start making some serious aggressive actions. That's usually take control, take control, take control. Okay, and that's kind of the big thing with any kind of angry, hostile combatant. You have to be the one in control. They can be angry, they can yell, but understand you're still in control, and they have to know that. Don't let them take that away from you, because if they can, then you're done. So keep your distance. Make sure you have extra people, even if you actually have somebody that was very angry and looks like they're getting aggressive, now they're cooled off. If you think there's a possibility they may get squirrely with you, bring a writer. They may be just cooling off and they're thinking, and all of a sudden the idea comes in, hey, it's just me and this person back here. What the hell? Kind of a thing. Keep your distance, and like I said, that whole personal distance expands at that point. But like I said, be firm, be in control. You don't need to be threatening, you don't need to be condescending, but be in control. Intoxicated patients. Big thing is main thing I want to tell you right now is do not try to be rational with people who are irrational. It's just not going to change. I don't care if they're intoxicated or not. They're irrational, don't bother with it. So a big thing I'd worry about is they may become violent. Again, take control depending on what they've taken. Now, usually it's drunk. It's like, okay, fine, we'll let you be drunk. I'll be honest, if they want to sit and lay on the, cot and giggle like a maniac, that's fine with me. I'm not that, really. And the thing I've actually seen with other medics, they sit there and try and talk to them and get information out of them. It's like, they're drunk. They're not going to say a whole lot. Don't try to make something happen that ain't going to happen. So, yeah. Don't respond with shouting. Depressed, suicidal, warnings, obviously no warning signs. A lot of times you're going to get there kind of after the fact, or attempt, or stated attempt at that point. And again, just ask them directly, have you thought about harming, were you thinking about harming yourself? How are you going to do it? And a lot of times I tell these people, it's like, look, I just got to ask these questions right away. And it's like, if you want to talk about anything else even more, that's up to you. I'm not going to poke and prod at you. And a lot of times they were very content with that, they don't need me, okay, no, you have to tell me what's going on. No, you need to tell me. I just need to know how you hurt yourself. Did you hurt yourself or not? Okay, were you planning to? If so, how? Okay, I'm going to leave it alone. And some people sit there and tell me, and then after a while, about 5 minutes of silence, they say, no, yeah, this has happened. But understand it's a very fragile state. Don't try to penetrate, their place where they're actually kind of feeling semi-safe at that point. Provocative patients. So, there I was.
Oh no.
Ladies, a suicidal lady, right? She's probably about 32. at the time about 28. Go pick her up. She's drunk. It's her birthday. She's feeling suicidal. She's hanging around. She's out drunk downtown, and there's this like weird homeless guy following her around. She doesn't even know who this guy is, but he's just now trailing her around and stuff. You know, like, get
Probably
the-
the same one that helped you on that.
No, I
He
remember.
follows you around every
No, I remember these guys pretty well. I had a lot of interaction with them. Anyway, she doesn't want to go to the hospital and all this other business, and you know, she's depressed. She's got 3 kids all by herself. Da 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 da. Get her in the back of the truck, start talking to her. Next thing you know, she's like, "You have really pretty eyes." Yeah, whatever. Da 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 da. I really don't want to go to the hospital. Okay. Keep riding. Keep going. Keep going. If you turn the lights on, I'll let you do whatever you want to me. Just don't let me go to the hospital. Slide down. Scoot down right now. So, yeah, it happens. Just, again, be in control. Don't, you know, if I would have known that, yeah, somebody would have been riding with me, but that you create a safe distance or get in touch with your partner up front and say, hey, I got a problem here. I'm going to be talking
It's
to
like
you.
safe distance, there's not much room in the back of those kind of things.
No, it was actually me sitting I was actually sitting at the head of the cot. I was actually sitting on the cot. She was sitting on the bench. I said, scoot down towards the back doors. It's like, don't even get near me at this point. I don't want you near me. And it's kind of one of those things, get out of the truck. Will you help me out? Nope. Get out. Don't. Yeah. Like I said, you gotta care. Something, it's kind of frustrating. That's dealing with sick people and injured people is easy, in my opinion. You get shot up with bullets, hey, not a problem. You know, you're septic, hey, not a problem. Even you got the sniffles, not a problem. People that just like to cause problems, that's the problem. Those are the tough ones, you know. You got these yo-yos, or you know, you got the person that's just, you know, wants to argue with you for the sake of arguing with you, or you know, wants to start a fight or something. That's the one that, you know, that's the one that actually can do the wear and tear on you. Patient with confusing behavior or history. Mental illness is a very, very real thing. I think I told you about the schizophrenic downtown. He was actually diabetic, which was kind of an interesting thing, but I mean, he was very typical of schizophrenic. I mean, one day we caught him at Taco Cabana pulling out trash and like reorganizing and decorating it. It was kind of cool. I mean, but you talk to him and you start trying to keep the conversation. You just watch him go off. Then you try to get back. He'd kind of get back, and you could just watch his mind. That was normal. That was actually very normal for him. But yeah, you got like I said again, patterns and things like that. You got to kind of keep an eye on that. But confusing history, behaviors again, is it, you know, a metabolic medical issue, or is it a psychiatric issue, or is it a little bit of both? You know, I haven't run into patients with multiple personalities.
Did you get to talk to both of them?
Yeah, scared the hell out of me.
Yeah. Like, 2 separate charts,
Yeah.
you keep charts of this patient, charts of this patient.
No, we didn't keep 2 charts.
He's like, what's your name?
Yeah, no, this was an interesting because she knew she had him, you know. Yeah, she was really interesting to talk to because she was like, yeah, she called because like a week of her life disappeared.
Oh, wow.
And of course, and I'm like, well, what's going on? She's like, yeah, I've got history of this, that, and the other. And she was really pretty open about it. I was like, yeah, I've got a real bad, very abusive family, this, that, and the other, da, da, da. She was telling about her different personalities and how they had these weird traits, and one was this way, one was that way. And so, I mean, people had witnessed, so she'd been working through, a lot of times they try to work through and start merging the personalities. But,
Did they have names? Did she tell you?
yeah. Yeah, I met her. I just remember. I forgot what her name was, but I remember that the next personality was Amanda. You know, Amanda was her problem personality. I got to meet Amanda.
Oh, nice, of course.
And
Yeah, you don't get to meet the nice one.
huh?
You don't get to meet the nice one, you get to meet the one that's causing
Yeah,
the
but
problem.
it was one of those things like you kind of, you know, we dropped her off. I was like, oh, I gotta go get a signature. Go back in the room. And it was like the creepiest thing because her whole body language was made such a change. You're just like, I'm like walking in like, this isn't
I've
right.
never met this person before.
Yeah, and this person's kind of looking at me and just kind of just the whole facial expressions, body language. I'm like, that's creepy. This is
You see
creepy.
people who fake it, but that would be weird to see somebody who truly
Oh, it is.
couldn't control it. They just
Missed a week of her life.
Yeah, there was another one that I remember we took up to Denver one time, and she had this sadistic personality that would like to cut herself. I mean, she had scars in her neck. I mean, just all these razor scars everywhere. So, Language barriers, like I said, are difficult. If you can get an interpreter, great. If not, we got to default. We got to take them. We will be a lot safer taking them than trying to decide. No, I don't speak Mandarin Chinese. But yes, I let them go anyway and find out, they had a big old, broken neck or something. Huh?
So unless your partner's Chinese.
Yeah. You just happen to speak that dialect too? Working with an interpreter depends how good the interpreter is. Depends how fluent they are in both languages. I mean, it's kind of interesting when they actually go into a Hispanic family, they speak Spanish, but the only one who really speaks English is like the 10-year-old, and you're bouncing between the two.
Right.
That's an interesting day.
And there's things 10-year-olds you just don't need to hear or know.
Yeah.
Medical,
Well, you got to break it down. And then, like I said, one of the things you got to worry about that loss of translation. What gets lost in translation, kind of a thing. That's really the big gist on that one. Intelligence and literacy. Does the patient really understand your questioning? People just function at different levels. It happens. So, can the patient actually read? I actually ran into a couple. This was funny. I ran into two people that said they were actually claimed legal disability, that they could not read and write. And I actually had one of them sign their name on the paperwork. I was like, uh-huh. But yeah, they had to say, I cannot read and write, I can't do this, and I remember my partner like, can you sign this for me? Oh, okay. One guy was just like, no. He was like, I can't, I don't need, so.
Yep, and we're paying for the disability because he can't sign his name.
Actually, I was wondering, this is speaking of interesting disability. Yeah, downtown Austin, we're sitting there, we're parked at a stoplight. See this blind guy doing this. Then you're sitting there, Austin does this. And I'm kind of like, come on, you're like screwing this for everybody else. That's the thing that gets me. It's like the people who have these kind of problems, you're just like making life harder for them, and that's what really gets to me.
That's awesome.
Okay, hearing impaired people, a lot of times they read lips. You don't need to over-exaggerate for them. They're pretty much used to reading lips, like everybody else, like people normally talk. If you know sign language, great. If not, vision impaired, a lot of times it's just tell them what you're going to do before you do it, and tell them, like if you're going to do an IV, I'm going to put an IV, and a lot of times they'll just like, can you feel it right here? Okay, I'm going to poke you 1, 2, 3. But they know exactly where it is. It's, like I said, you don't want to catch them off guard and surprise them. Wow, what was that? Common pitfalls: choosing to ask lots of questions to obtain history without directing initial care to perform an exam. Again, this whole point is be systematic. We just want to be systematic in what we're doing. And again, the patient's impression: if you look like you're a chaotic mess, they're going to think you're a chaotic mess. That's all. That's really what it's going to come down to. You ask a bunch of meaningless questions, like I said, that's all they're going to take you. Tone of voice, like I said, just everybody's going to kind of have to find their own tone of voice. My thing is just, if you ever want to see actually interesting ones, go talk to people or look up people who do voices for like animations and what they do and think of. I actually saw the guy who did the voice for like Optimus Prime, and he was just like, well, I thought more of kind of that crown on my head and talking from this, and that's how he emulated himself, and that's how he came up with the voice of Optimus Prime. But if you actually listen to the guy talk, you would like, it sounds like some guy from like straight out of New Jersey, but he can switch. But so it's interesting just to talk to those guys or listen to those guys, how they kind of come to developing the voices or what they think of and so forth. So, and what is your problem today, Mrs. Jones? What can I do to help you this evening? Yeah, you can kind of guess what kind of impression they're going to do. Why did you call 911? Or like, and we do, and I've seen this happen. I've done this too. So, what exactly happened at 3 o'clock this morning that made you that made you want to call? You're kind of like you're frustrated with them, and you're kind of catching. But just be careful with that. They don't things not looked highly upon. Cultural beliefs and okay, the whole herbal remedies thing. Some of you're going to find you're going to be like, it's going to be WTF over. I mean, just to put it mildly, I mean, I took this lady from out of Round Rock one day, and she was having a massive asthma attack. Well, she kind of like made this like little mush, this weed mush thing, and was sticking it on her forehead. and of course, we get there, you know, she's having problems breathing, and she's just got this big old spot, red spot here, and we're doing, you know, we're doing nebs and all this stuff, and like, so she's like, yeah, you know, she's telling me she tried to treat it with herbal remedies, and she stuck this thing on her head, and this was supposed to, you know. So of course, you know, you're listening to this, you're like, okay, if I drop her off to the hospital, you're like going, you know, doing that. So, but yeah, people. The interesting thing about people, this is
You have enough kids. That's awesome.
That's awesome.
yeah. Just be careful with your cynicism out there. It's very easy to do.
Actually, I feel really guilty. On one of my rides, when I did the EMT thing, there was a woman that's pregnant. Who was possibly, she was 6 months and was possibly going to miscarry the baby or
Yeah.
deliver early. Hasn't been to any prenatal checkups or anything like that. And here I am, and I'm like, you know, I'm trying my damnedest to have a child right now, and you don't deserve one. That's all I kept thinking in my head while we're in the back there. I'm like, you don't deserve this child right now. And she has 3 other kids that are all under the age of 3 that haven't seen a doctor either. So I feel bad because I've actually thought something.
Well, then I wouldn't feel bad. Just understand it's, well, one, understand it's human. And like I said, it's, you don't want to convey that to the patient. You know, that's one of those things you just kind of compartmentalize. And yeah, I mean, because you get us behind closed doors, we're going to be doing the same things like, you know, that's a bunch of crap, you know, or it's like, wait a minute, this girl's 19 years old, she has 4 freaking kids, and nobody's doing anything about it. It's like, the kids, you know, you're going to get angry. It's like the kids are the ones who are suffering. But of course, you know, when you get in there, you can't convey that. You got to be that kind of that impartial. But don't, I wouldn't say feel bad about it. I mean, for some reason we
So I shouldn't feel guilty that I'm thinking that this
It's
woman
normal
doesn't deserve the child that she's carrying right now.
I wouldn't. I mean, I don't.
I feel bad about you.
We this is ironic. We don't ever want to negate a patient's emotions and their state of mind, but we always want to negate ours. And I think that's such a complete, I don't know what's the word I'm looking for. I mean, it just makes absolutely no sense because we get the same thoughts and feelings that they'll get, and the same reactions too. It doesn't make us any better or any worse. It's just whether how you act upon it really changes it. You know.
That would hold professional.
You know, yeah, the ideal thing that we want, well, again, there's the ideal world that we try to emulate, but the thing is, you know what, we're all people too. And for some reason, we don't like, our society does not like that. We don't want to be real people. But she laughs at the traditions of my cultures. Yeah, we probably will.
Probably.
It's
Yeah.
funny.
You know, because, I mean, realistically, I mean, they might be even laughing about you later. That's just human nature. I wouldn't take it, you know, personal though. Poor choice. How many years has your husband taking ACE inhibitor? I don't think that's a really bad one. I think the point they're trying to take is talking above their head. You know,
Like deliberately or just
unintentionally. You do it unintentionally sometimes.
Or using technical terms.
Yeah, we start using our little technical jargon, and sometimes it's kind of like you got to kind of watch them and catch them. You know, and it's like, okay, this is what we're asking. You have to break it down in layman's terms. I mean, it's kind of like, you know, going and talking to people that do computers all day. They start going, I'm like, it's like, look, I know how to open the MacBook, I know how to hit on, and I know how to get on Safari. That's cool. You know,
but it's kind of double-edged sword too, isn't it? Like talking below, like so now you're talking like
Yeah, and then
They're
you come
dumb.
up and you're like,
No,
well,
you don't
just
talk about
heart
they're dumb.
failure.
no, but you know, like trying to explain to them
Like they may be offended.
like a
if you
kid or
come
you know,
down
like you
for
would
them.
explain it
You
to a
don't-
kid.
talk it to the way they understand. You know, I mean, like you guys are going to be working with EMTs. They're going to ask you what, well, you know, you're going to talk about this, and you're going to look. You're like, okay, this is what it means. You give them something that they can relate to. That's all you're doing. You know, I mean, sometimes you might have to, you know, if they are that, you know, electrical engineer, break something down to an electrical engineer terms. Like, okay, now I see what you're talking about. Something they can relate. But the thing is, this, you don't want to start talking too many medical terms that like they're just completely lost. Like, what the hell's going on here? What does this mean, and so forth. So anyway, history guide. History guides the physical exam. History take is accomplished to do along with physical exam. You do those things simultaneously. Just remember, your exam's going to be 20% done quick. Like history is going to be the rest of it. For emergent patients, obviously we deal with the big stuff. You know, obviously if we got to deal with big, bleeding and the airway issues, we're dealing with big and the bleeding airway issues first. We can backtrack later if we have time. So, in like some of those cases, you may not get a history at all. You might just sick patient, patient's dying on you. You're busy. You're busy working. You may not have time to get anything.
That was one thing I was worried about, was like, am I ever going to have time to do this?